right, so got a lot to cover. I know you had your OSCE this weekend. Hope that went well. This session will be recorded as the one yesterday was. If you weren't able to watch the one from yesterday on neuro, I'll reiterate a couple of things. You guys being in term 5 now, there's not much explanation or understanding, comprehension at this point. Unfortunately, this is a lot about memorization. So what I'm going to do, being that there's so much material, I'm going to go very quickly. It'll be rapid fire. I'm just going to point out very testable points. But unfortunately, there's not a lot I could do with the antibiotics and some of these drugs. It's just you have to sit down and memorize them. So I'll just point out some of the things that came up for us, some of the things that are coming up on UWorld that I'm studying right now for STEP. So just the high yield points. So by all means, if I go too fast or if you miss something, just stop me. You won't hurt my feelings. And if I say something incorrectly, you could please stop me too. After 3 hours of talking, I don't even listen to myself. So yeah, we'll go ahead and get started. All right. I did want to do something yesterday that I forgot to do, and that was just do some rapid fire with the tracks real quick. So I'm going to share my screen and we'll just touch on a few things just in case y'all get some of those questions. Let's see. All right. So if we look here. So if we remember the 3 major tracks, let's see if this works. There we go. We'll call this the brain and our brain stem. Just very crude. Remember the ALS is just gonna cross at the level of the lesion, okay? The DCML, which is also, wait, let me do this because these are ascending tracks, right? The DCML is gonna come and cross at the base of the brainstem, okay? The base of the brainstem. And then conveniently, the corticospinal tract, which is descending, will also cross at the base of the brainstem, right around where the ALS is, okay? So we'll call this area, this is the base. Okay, so the caudal medulla is where they cross. So just keep in mind when they give you all these track questions, if it's some sort of, say, hemisection, if you had, like Brown Secord, if you had a hemisection, half of the brainstem, you would expect the contralateral ALS to be affected. And that's because the ALS crosses immediately. So you would lose contralateral ALS sensation below the lesion. And the DCML and the corticospinal tract would not have crossed yet, okay, because it's the base of the brainstem. So I believe first aid has a really good, just a 1-page summary of the different lesions. If you can go through that, you should be fine. Couple of other things. So if you had one, well, I guess, well, let's see. If you had, this is a great drawing, as you can see. If you had one side of the head and then the contralateral body affected, right? It would probably be somewhere at the level of the brainstem. This is in first aid as well on that page. And that's because all of the nerves to the face, the cortical bulbar tracts and whatnot, they cross a little bit higher up. Okay, so if you do have, say, left side hemiparesis or left side deficit and right side of the face, you can expect it to be somewhere in the brainstem. Okay, because remember the cranial nerves stay ipsilateral. Okay, but once they go through to the brain at the level of the pons, a little bit higher up, they cross over. Okay, now the other one would be if you had something like the whole side, right? Now, if everything is on one side, it has to be up in the brain, correct? Because everything would have crossed already. So I have a picture here that I pulled up for you guys. Sorry, let's see. The internal capsule, if they say left side face and body lost motor and sensory deficits. Okay, this internal capsule is a track, white matter track that connects these primary sensory and primary motor cortex down to the body. Now, once you get to the base of the brainstem, it would cross. So internal capsule is a good guess there. Now, if they tell you specifically that it is a sensory loss or a motor loss to that side, then maybe you can go a little bit higher up and go to the sensory and motor cortex, right? And you remember those, if we draw the brain, kind of looks like a boxing glove. It's not that good either. You have the central sulcus around there, and you remember that the sensory is on in the frontal lobe, the posterior part of the frontal lobe, and then the motor is the anterior part of the parietal lobe, separated by the central sulcus. Okay, so again, if you have loss of the whole left side of the face and left side of the body, motor and sensory, maybe internal capsule. If they say specifically it's just sensory and motor loss, maybe it's way up in the brain at these primary motor or sensory cortexes. Make sure you can identify the central sulcus on a lateral view and a medial view. Another point, what's another point? Cerebellum is ipsilateral. Okay, so any sort of cerebellar issues, you have this, remember all those words, dysadicokinesia, dysmetria of the right hand or whatnot, it's the right cerebellum. So yeah, I think that's all. That's all I can think of off the top of my head. So let's go through these. And again, this will be rapid fire. We'll try to get through it quickly. So I know you guys have better things to be doing right now. Right, okay. So we're gonna go through some of these infections, right? Anytime you see photophobia, nuchal rigidity, you're definitely thinking some sort of meningitis. You wanna see how long ago it's been. Now, we'll go through some of the testing when we get there. Let's see. Right, this just kind of defines what the meninges covers. We want to get to some of these because it's very different. And this is very important. There is a star here when you talk about meningitis in different ages, because it's as you're going along here, I know back in year one, sometimes the age wasn't important. In these sorts of situations, the age is very important. That could be the only giveaway you get. So neonates, group B strep, that is usually during delivery, neonates can contract this if the mom has it. But strep pneumo, of course, babies and children, strep pneumo is number one. It is teens and young adults. Look for the SGU. Let's just go with this. Neisseria meningitis, college age. We'll go with that. There is some different evidence that would say otherwise right now, but this is what the school wants. So this is what we go with. And of course, older adults, strep pneumo as well. That's why you try to immunize these babies and children, and especially older adults. Remember, it's only the Hep B, the Haemophilus influenza type B, that is that you can get an immunization for because of its capsule. The ones that are non-typable that can cause ear problems, those are not covered under this vaccine. So I would definitely know these. These will help you out knowing which age groups go with these. So that was the main thing I wanted to point out there. And then they go into some of the other ones. Y'all remember this from your test, your OSCE. Chocolate and blood agar used for those gram negatives, Neisseria, Haemophilus, right? Depending on if you add some of the other factors to it. And remember, meningitis can lead to a normal pressure, a communicating hydrocephalus as well. If you get scar tissue on the meningitis, on the meninges, those arachnoid granulations cannot drain into the venous system. So you can get a communicating hydrocephalus. This is very important, okay? So the first thing when you're looking at these lab values, you wanna see if there is opening pressure should indicate that there is an increase in intracranial pressure. Ideally, you would have gotten a CT scan before you did that. But you want to look at glucose. That's the first thing I look at. If it's low, if it's very low, it's typically bacteria. fungi can mess with it a little bit too, but it usually doesn't drop as much. And then you look at the white blood cells. If they're neutrophils, it's going to be bacterial lymphocytes. You're thinking it's either viral or fungal. Okay, so and the protein will be elevated in all of them, so it's not really helpful. But yeah, you definitely want to look at the glucose and then what kind of lymphocytes are there as well. So that'll help you out. Cloudy CSF, sure, yeah, that's a lot of neutrophils and stuff like that that are in the serum. All right, so screening tests, let's see. Right, okay, so good, here we go. So these are for the little kids. Group B strep, as you get it during delivery. E. coli is another one, and listeria, right? So keep those in mind. All right, and then it kind of just goes into the different ones. You know, this is one of the things that now, studying for STEP, that, you know, I wish I would have burned into my brain better, a lot of these little characteristics, but you know, hopefully if you know some of these, that'll help you with differentiating some of those answers. Right, so this just kind of goes into the different characteristics of it. High risk food, soft cheese, yeah, of course, for listeria. Right. Oh, a good differential there. Yeah, for listeria. Remember, listeria is, so it's typically, you could get it, yeah, it's one of those weird things that can grow at cold temperatures, so in the refrigerator. But it is an intracellular organism, so it's one of those weird things on your labs. You might get increased lymphocytes versus neutrophils, and that's just because it's intracellular, and the neutrophils can't really do anything with that. Okay, so we're looking at over 1 year old, of course, strep pneumo around infants and old people get that, and then Neisseria is number 2, and get some other ones. I did write this in here. Staph aureus, hospitalization, head trauma, any sort of penetrating wound. You're worried about the staph infection from the skin, and then unvaccinated infants and children. Remember, when they put that in the stem of the question, that they immigrated from somewhere, they're not vaccinated, don't skip over that, like highlight that they usually put that in there for a good reason. If y'all are doing New World questions, you'll find some that they throw a bunch of extra information in there that'll definitively throw you off. But for now, just keep in mind that those are important points. They want to know if you know what kind of bugs are able to be vaccinated against. All right, so let's see. All right, strep pneumo, that's the big one. Here's the 4 that it can really cause. Capsulated, alpha hemolytic, those are good to know too, right? So it's partially hemolytic, whereas strep pyogenes is beta hemolytic, right? Vaccinations for high risk, those are our kids and older and elderly. All right, in meningitis, right? So that's going to be like, I think right around college age, that's where you're thinking about that. Facultative intracellular, this lipooligosaccharide is a very toxic agent. That's what could lead to, when you think of Waterhouse Friderichsen's or bad sepsis, which would cause adrenal issues. Not that y'all need to really focus on that right now, but that LOS is what causes that. It's very toxic. You're worried about asplenic patients. Remember, this is for asplenic patients. It's Shin. Not that there aren't more, but it's staph, Haemophilus influenza, and Neisseria. So who are patients that don't have spleen classically? That's going to be people like people with sickle cell or whatnot, or some sort of hemolytic anemia that's causing extravascular hemolysis, clogs up the spleen, and you end up having to take it out and whatnot. All right, let's see what else. Chocolate agar, Thea-Martin specifically for Neisseria, gonorrhea as well. Use that Thea-Martin. It's chocolate plus some other stuff in it. And then let's see, yeah, see the lipooligosaccharide, that's that endotoxin that could cause really bad sepsis. And then anything IgA protease. Remember, IgA is in mucosal surfaces. So if you could, protease will break down the IgA. So if you could break that down, it helps with colonization and invasion. Any little thing you can read into this, like that helps me out. If we break down IgAs, seems like you can get through the mucosa better. So anything you could try to remember like that, the less things you have to strictly memorize. All right, and of course with Neisseria meningitis, meningococcemia, because it is a diplococci, that's what you worry about there. And then petechiae is disseminated DIC, right? With DIC, typically they may not tell you the patient has DIC, but when you do the coagulation profile, right, you look at the APTT, stuff like that. Everything's prolonged. You're low in platelets, your bleeding time's prolonged, and that's just because everything's getting used up. Okay, so this is kind of like this, your body just doesn't know what to do with itself. It's just got so much going on that you just start making little mini clots. And that's what I said earlier, this lipooligosaccharide, that's what can lead to this Waterhouse-Friderichsen syndrome, which is basically, yeah, you get this adrenal gland, lack of blood flow to the adrenal gland, and yeah, it can, due to this bacterial infection, right? All right, one of the one of the things that is specific about it, these little petechiae on the body, they don't blanch, and it extends to the palms and soles. Okay, so that's one of the classic things about this. They may just give you that information. And right, so you can get vaccinated against. Right. So again, when they tell you something like unvaccinated infants and children, you're thinking of, this type PH influenza that it could cause, okay? And then it goes into Staph aureus, right? Remember I mentioned skin infection, penetrating wounds. Look at that abscess that forms. Yeah, so that could be from Staph aureus. And you can see, you can even get it from the ear canal. Okay, I'm not big into charts, but if that's your thing, it's all there. All right, I went a little long on that one, but those are super important. Remember, y'all know by now, the things that are most common in the hospital, the things you're gonna see the most are the most common things that are tested. So some of this other stuff isn't super high yield. All right, what else? Yeah, meningoencephalitis, right? Okay, so let's see. Right, so specifically, very specific, make sure you know this, temporal lobe encephalitis, right? Typically, if it's a viral infection, you're thinking HSV, herpes simplex virus. It specifically causes temporal lobe encephalitis. So whenever I see that, that's the first thing I think of. Let's see, okay. Right, and again, you're not gonna get a decrease in glucose. The reason when bacterial infections that you get a decrease in glucose is because bacteria eat the glucose to survive. You're not gonna see that in viral meningitis, okay? Also, you're gonna see lymphocytes instead of neutrophils. So the lymphocytes are gonna be elevated versus the neutrophils. Big ones here, these enteroviruses, polio, Coxsackie, and echovirus. Those are the most common causes of viral meningitis, okay? Then it kind of goes into these details, right? Different classes. Hopefully you remember those. I know those are tough. There's so many of them. Ideally, polio is kind of out. There have been some reports of that due to this wave of not getting vaccines, but you're not going to really see that too much. Goes into the different vaccines. I don't know, kind of important, kind of not too much. Mumps, anytime you see parotid gland enlargement or parotitis, right? That's the first thing I think of is mumps, okay? Unless it's some sort of cancer like Burkitt's lymphoma. But if you see an infection, mumps can also cause orchiditis, right? Inflammation or infection of the testicles, or you can see that here as well, right? Okay. And then you have the herpes virus that could form, HSV1, classically contracted during childhood, right? They say HSV1 is up top, HSV2 is down low, but that's changing as well. So this is what SGU wants, so that's what we'll go with. Right, and you know that HSV, even varicella, these are reactivations, okay? So varicella is the one, right, that you get as chickenpox, and you come back to shingles, has that dermatomal distribution. Latent, you can end up getting, I forget what it's called, herpetic neuralgia with that, which is intense pain from that. But HSV also has a reactivation, so you need to know that. Again, make sure you know this, temporal lobe, classic presentation, temporal lobe encephalitis, you need to think about HSV. All right, rabies, that's kind of a weird one. You get that hydrophobia, difficulty swallowing, stuff like that. But it does travel up the PNS and go the peripheral nervous system and the olfactory tract to get into the CNS. So that's a very unique characteristic of rabies. Some of the diagnostic clues here, these Negri bodies. Yeah, so typically you don't get only veterinarians, to my knowledge, really get this prophylactically, but you can get that if you end up getting bit or suspected rabies. Then it goes into the arthropod vectors. Yeah, we all know about West Nile and stuff like that. Rodents, not rodents, it went from rodents to flies, right? Is that right? Or is it just flies? I'm thinking, we'll see what they say. Birds to mosquitoes, that's what it is. Birds, yeah, the avian flu, yeah, that's right. Yeah, so birds to mosquitoes, right? And then the humans can be affected. Of these here, I mean, I would think West Nile would be the big one to know, just because it's very recent. I get that one confused with Yersinia. Yersinia is the one that has the rats, right? Okay, no, let's see. Right, immunocompromised patients, JC virus, PML, that's good to know. Yeah, for sure, you wanna know that. Anytime they talk about immunocompromised, you have this whole slew of different type of infections that can happen. Now, when we talk about these fungal infections, it will be cloudy. You'll get a small decrease in glucose. It shouldn't be as much, but the difference here is that from bacterial infections is you have more lymphocytes versus those neutrophils. All right, and again, fungal infections, typically you're gonna see in your HIV AIDS or your immunocompromised patients. Cryptococcus, bird droppings, Candida is very common, maybe hospital acquired, but if you're thinking of thrush or anything like that, Candida is the first thing that really comes up. So just knowing buzzwords for this is gonna be good. We'll look at Cryptococcus. It always has this big shell around it, okay? So if you all see this clearing right here, that's classic Cryptococcus. You can get meningitis that way, meningioencephalitis. Again, big thing here, and we'll talk about it when we get to the AIDS lecture, but they give you this specific T cell, this T helper cell count, because at under 200, you're susceptible for pneumocystis jirovecii. Under 100, Cryptococcus comes into play. Under 50, you have things like CMV and other things. So it is good to know which, at what point you're susceptible to different things. So they usually do the 200, 150 thing. So it's definitely good to know that. All right, and this Cryptococcus India ink is the classic one, but you can see with all of these, you have this clearing, right? And that's because of that huge capsule of Cryptococcus. All right, yeah, not super definitive, but you can see these little, it's better, usually they'll give you something like this, these stains to kind of show you that big wall, but these are not specific, these little spots. And then Candida, big thing about that, when you think of Candida, you think pseudohyphae. That is classic for that. The way the hyphae branches, it's a pseudohyphae. So whenever they say that, I think Candida. Anybody with neutropenia or immunocompromised, you're worried about that. Okay. And right. And then specific for tuberculosis, what you'll see is they do use the glucose and you do get increased lymphocytes. Now, it's the same thing with Listeria. Mycobacteria or tuberculosis is an intracellular organism. There's nothing the neutrophils can do with that. So to fight off these stuff that are intracellular, being viruses, being Listeria, being tuberculosis, you're gonna need to use neutrophils, right? You need those CD8 neutrophils to kind of go in there and try to do some damage for those intracellular stuff. So that is an exception, right? You would expect the bacterial infection, you see there's low glucose, but all of a sudden you have lymphocytes and you're like, well, could it be fungal? But it seems like it's bacterial. Maybe it's an intracellular bacteria like Listeria. Now, if you look over here, the tuberculosis, it does make these fibrin webs, but because it's intracellular, you would see a lot of neutrophils. All right, some of the specific things about these acid-fast bacilli, meaning they don't stain well, mycolic acid, cord factor, You'll see that there. Again, you know this by now, it is a reactivation thing, and you see those tuberculomas that form. All right. Then some spirochetes, right? Lyme disease that could lead to it if it's not treated soon. Right, and you get this from tick. So if it's not treated, you end up getting neurologic symptoms, papilledema, facial palsy can cause Bell's palsy, and stuff like that. Remember, these cause that target lesion that you get usually by hiking. And then another spirochete is syphilis. You can end up with neurosyphilis, tabes dorsalis, degeneration of those nerves, but pretty much weakness that you can get there. So again, if the syphilis isn't treated well, you could end up with neurologic symptoms too. So be aware of that. All right. And correct me if I'm wrong, I think tabes dorsalis is only a sensory issue. Double check that one on me. But if they're talking about a sensory issue, maybe you're thinking syphilis. All right, what are we looking at? White patchy lesions in the oral mucosa, right? Whenever they talk about that leukoplakia or candida, thrush, candida can be scraped off, leukoplakia cannot, okay? So leukoplakia can be a precursor to some sort of cancer, but we'll see what they're talking about. HIV, so immunocompromised, looks like it could be candida, right? And then we get into the parasites, or you know what, they could actually be saying, they're not saying this is the cause of the encephalitis or brain pathology, but they're just telling you by saying these two things that the patient's immunocompromised, so they're susceptible to a number of different things. So we'll look at the parasites, right? Toxoplasma gondii, cat feces, pregnant women shouldn't be around. Cats in this regard, you get this necrotizing encephalitis. I'll show you exactly what they like to test on when we get there. Negrophaly, butchered that one. This one, meningioencephalitis, travels through the olfactory nerve. What's the other one that does that? Rabies, right? And then Tinium solium, if you work on a pig farm or a farm in general, you're worried about that. That's a tapeworm, can lead to seizures. Okay, right. So again, being immunocompromised, they're worried about that with pregnant women as well. Cats, natural host. You're worried about inhaling feces. So the big thing here is these focal ring enhancing lesions. That's what they'll say, right? These focal ring enhancing lesions, they're kind of all over the place. They're diffuse, you can see them. But if you see a picture of this, these lesions here, these ring enhancing lesions, that's very characteristic for Toxoplasma gondii, all right? You could see here brain eating amoeba. Now, I'm not even gonna try. Yeah, so you can see that, and again, it travels through the olfactory nerves to get to the brain, and then that pork tapeworm, Tania solium, you can see that here, but what you're worried about that is some sort of exposure to pigs. And then it can cause neurocystic necrosis. With that, sometimes, so you get this star sky effect, sometimes the brain pathology will not show anything, okay? So it's not very indicative like this, but there is evidence from clinical evidence like seizures or headaches, but it's not necessarily gonna be as easily defined as this. But for right now, the starry sky appearance, I believe these are little calcifications and stuff that you could see interspersed, okay? All right, Clostridium botulism. Here we go. We'll use that. AB toxin. They talk about swelling cans, right? If you have cans at home, if you buy cans and they swell, that's usually because there's some sort of botulism in it, or any sort of home canned vegetables or even honey. They use that one too. That could come up. So think about botulism. You could see here. So botulism will cause Botulism will
flaccid
cause
paralysis.
Flaccid paralysis. Thank you very much. Right, and tetani will cause this spastic paralysis as well. Right. So right, of course, because botulism toxin, right, they use it for injections to eliminate wrinkles and stuff, right? Because it causes flaccid paralysis. It prevents presynaptic release of the acetylcholine. Okay, so that's going to be what they use there. And Clostridium tetani, that has that AB type toxin as well. And yeah, that's going to cause, you know, the spastic paralysis. If you're ever exposed to step on a rusty nail, they'll ask you when you got your last tetanus shot. Hopefully it's within the last 10 years. If not, you need to get one. Okay, so Clostridium opposites, remember botulism will be flaccid, tetany will be spastic paralysis. Okay, as I said, presynaptic acetylcholine, and with tetanospasm, it's presynaptic glycine and GABA. Okay, so yeah, so in that regard, you're blocking the inhibition. So the glutamate has unopposed stimulation, so it'll cause this spastic paralysis or rigidity. Okay, then you go to some of the other ones, prions. Remember, those are just proteins that form. They're not exactly living or creature. Well, you know what I mean. They're not like bacteria or viruses. They're very different, and they're these coagulated proteins that come together. But they're really hard to kill, right? So I can lead to dementia, involuntary movements, or seizures. Yeah. Remember that if they ever talk about somebody that had some sort of surgery, brain surgery or whatnot, prions aren't really killed on the autoclave and stuff like that. So they're very difficult to get rid of. So if you get some sort of transplant, some sort of corneal transplant, it can lead to this. This is what happens is transmissible spongiform encephalopathies in humans. All right, goes through these in a little bit more detail. This is the big thing. This is like from FTM1. The normal prion is in alpha helices, but as the infective phase, it turns to beta pleated sheets. That's still a testable fact. Okay. Right, and this is how mad cow disease works as well. It's the same thing. Right. Ear infections, I mean, you know this by now. Pseudomonas is one, gram-negative. It grows specifically, it shows that pyanocyan. It has this green tint to it. Swimmer's ear also causes hot tub folliculitis, so think about water with this one. Staph aureus is a big one. Remember, because of the way that kids' eustachian tubes are directed, it's more, they're smaller, and the direction of it, they're more prone to ear infections. That's why they get them. You can see this mastoiditis back here, this ear infection. If it goes through the mastoid air cells, it can get to the brain. So you have to be careful with that. If they ever talk about the child tugging on their ear, that's usually because they have some sort of ear infection. Okay, and then you can go through this. But if you had to guess, definitely lean towards staph with these. Eye infections, right? I don't know that this was really highly tested. Adenovirus is what causes pink eye. Okay, so children in daycare, stuff like that, adenovirus, it's a big one that you want to be worried about. It can lead to diarrhea and stuff like that. But if they ever add the fact, because it's fecal oral, if they ever add the fact that the eye, there's conjunctivitis involved, you know, if you're thinking maybe rotavirus or norovirus, if they add the eye, go with adenovirus for sure. All right, and then HSV, always a problem, latent recurrent infection. You're worried about that in immunocompetent hosts, okay? But once you get to immunocompromised, CMV is a big one. As I mentioned earlier, under 50, your T cell under 50, which is very bad. I mean, so CMV is gonna be what you worry about at that point. I think mycoplasma is the other one at under 50, but we'll get there. We'll see when we get there. All right, staph, again, same thing. Y'all know this by now. Well, and then chlamydia is another one. One of the interesting, well, you know, defining characteristic that they always talk about chlamydia is these elementary bodies and these reticular bodies. I think that's what the R stands for, reticular bodies. Elementary are infectious, reticular are the ones that replicate, okay? So, yeah. That's how you remember that. If they talk about that, it's probably chlamydia. All right, and it can cause these trachomas, I think is how you pronounce it, that you can see there in the eye. So that's not good. Mucorrhizopus, when I think about that, I think about diabetics. That's the big one that comes up there. Diabetic with ketoacidosis. Those are the only questions I've ever seen about these two things, the patient had diabetes. Okay, but you can see that extensive necrosis, it's bad for the eye. I think DKA, that's a big one. Don't remember them ever asking about any of this. Right, and as I mentioned yesterday, this test has so much material and it's so dense. I mean, a 6-week course that you kind of have to pick your battles when learning this stuff. So the stuff I am skipping is just stuff that I don't remember them testing. So yeah, that's how that goes. All right, so let's get into the bone. You know, I think some of the bone pathology when it comes to the cancers gets a little difficult, but some of the other stuff is fairly straightforward. You've learned about osteoporosis and all that stuff. So we're going to skip through a lot of the older stuff. Remember osteoblast build, class eat it up to get it the calcium back into bone resorption, get it back into the bloodstream. PTH is the main player there. Vitamin D comes into effect, which I've learned that already. Yeah, so this is all review. Yeah, y'all remember this picture, right? Go back. Or not, don't go back. Y'all remember the picture of the zone of ossification and all that. I don't know that they're really test show on that since y'all been tested this, right? Reserve zone, proliferation, hypertrophy. So it comes from this way from the epiphysis to the diaphysis, and this cartilage grows and then deposits as osteoid, as bone, right? Right, okay. So again, this is kind of review, achondroplasia. I know about this autosomal dominant. Technically, it's a gain of function mutation. It gains the ability to close the epiphyseal plates. That's how they define it. It's fibroblast growth factor receptor gene. Definitely note that. It does have an effect with older, whereas Down syndrome has an effect with older mothers. They say that achondroplasia is seen with older fathers. So there does seem to be some sort of link there. And it goes through the process of this deactivation, this gain of function, where the growth plate closes early. Okay. And then OI, you've learned about this, type 1 collagen synthesis. So it ends up forming these triple helices. And so if there's a problem there, you end up getting weak bones. So the classic thing there, or before we get there, type 2 is the worst kind, type 1 is milder, but you do see this dominant negative effect, meaning that some of the collagen, some of the collagen that's formed is defective and some is normal. So, but the dominant negative means that that defective part is overwhelming the normal part, which means you get these fragile bones. Okay, so that's the effect there. The big thing that you see within osteogenesis imperfecta that doesn't involve the bones is the blue sclera, if y'all remember that. Okay, osteopetrosis, you can see here these brittle or marble bones. That's how they define that there. So osteoclast dysfunction, abnormal matrix turnover. Okay, so you end up with these brittle bones. Erlenmeyer flask kind of means it kind of goes, you know what an Erlenmeyer flask is from chemistry, right? It kind of goes to a point. It means that some of the bone has been kind of, chewed away. So it kind of comes to more of a point instead of being more linear. All right, let's see. And you can see that here, these brittle bones. So the problem with these osteoclasts, and so you get abnormal deposition. Ehlers-Danlos, connective tissue problem. Remember, they have the very stretchable skin, leads to scoliosis and stuff like that. They're at risk for Barry aneurysms as well. Marfan's, of course, you know that by now. Fibrillin, they get subluxation of the lens. Mitral valve prolapse, they can't play sports because they could get aortic dissection, damage to the media. Okay, so those should be easy points. Remember those from before, just brush up on them a little bit and you should be fine. All right, so this is dense. There's a couple of things that are important. Definitely the selective estrogen receptor modulators, right? Remember, tamoxifen is it is an antagonist at the breast, so it can be used for breast cancer, but it's an agonist at the uterus and on the bone. So you want it to be an agonist at the bone because that's going to prevent osteoporosis. You want it to be an antagonist at the breast because that's going to stop estrogen receptor type breast cancer. The problem is it is an agonist at the uterus, which could increase your chance of uterine cancer. Now, ideally, you wouldn't have to use that because they came out with raloxifene. Now, raloxifene is an antagonist on the breast, good for breast cancer, antagonist on the uterus to prevent uterine cancer, but it's an agonist on the bone. So when you get when women, postmenopausal women, you can actually give them raloxifene, and that will help with the bone resorption or the bone deposits, mineralization of the bone. That way they don't end up with osteoporosis. Now, the other thing from this that they talked about were these bisphosphonates. So we can get there. You know about parathyroid hormone. Now, let's just real quick. So vitamin D, once it's activated in the kidney to 125 vitamin D, then it's able to, it goes to the cell. It's a nuclear receptor. It goes to the cell, and you're able to pull in calcium and phosphate from the gut. Okay, so increased calcium and phosphate. For the bone, PTH works, and it can reabsorb calcium and phosphate from the bone. So blood calcium and phosphate go up as well. The only difference is that PTH also works in the kidney, so it can bring back calcium into the blood, but also pee out phosphates. Okay, so that's the place where you're kind of getting rid of phosphates. It's just a common question that comes up. All right, and that's what they're talking about here. All right, and then they talk about these bisphosphonate, potent inhibitors of bone resorption. Okay, so osteoclast apoptosis. So if you prevent the reabsorption from it, you can try to keep the bone stable. Okay, and then I don't know that it really went into the generations of it, but just knowing how bisphosphonates work would be a good one. It can lead to erosive esophagitis. I thought there was maybe that was it. Is that the big, does anybody know any other big side effects of that? That may be the one. Okay, yeah, so definitely know that. I think that's the only thing really that they worried about for this. Yeah, we mentioned the SERMs. Calcitonin is it's basically activated vitamin D. Who needs this? People with renal failure, because remember the kidneys are converted, it's converted to 125 vitamin D in the kidneys. So if you can't make that, you get calcitonin. Osteomalacia is basically rickets in adults, so you have decreased vitamin D, okay? So that could lead to that. Paget's disease, I think there's another lecture that we could talk about that. But very importantly, in Paget's, your serum calcium and serum phosphate are normal. The only thing that's elevated and diagnostic for it is the elevated serum alkaline phosphatase. Alkaline phosphatase is always elevated when you have increased bone turnover, right? So remember Paget's disease, there's the clastic phase, there's the mixed phase, and there's the blastic phase, meaning that it's always turning over. So that's going to end up giving you an increased alk phos. All right. Goes into this, not super important. Okay. Yeah, that's good. All right, so some of these metabolic bone diseases. Okay, so rank in, rank out is going to kind of is going to kind of regulate your osteoclast. Okay, you need both of those to get the osteoclast going and working. And a direct inhibitor is osteoporoterogen. Okay, so those work against each other, but when you see rank L and rank working, it's basically to activate the osteoclast. And it is on the osteoblast, which is kind of weird. So once you get this expression on the osteoblast can signal to the osteoclast to come reabsorb some bone. Okay. Osteoporosis, you're just getting decreased bone, right? So typically this has to do with estrogen. Estrogen actively inhibits osteoclasts, okay? So if you have decreased estrogen, you're postmenopausal, you don't have this inhibition of osteoclasts, you can lead to osteoporosis. Put them on raloxifene, okay? Yeah, raloxifene, right? Not tamoxifen. Happens with age, decreased estrogen, there you go. And that's a good picture for it. You can see how the lack of density that's there. And then of course, anything hyperparathyroidism, just mention that again, increased PTH. Now look, you don't actually want to take, you don't want PTH to have to take calcium off the bone if you're hypocalcemia. That's a last ditch effort, okay? But if it comes down to it and you have something like hyperparathyroidism, you're gonna start eating away that calcium from the bone, okay? So you're gonna deposit calcium. In the bone, it's deposited as calcium phosphate crystals. So you're gonna pull the calcium phosphate back, okay? But also with hyperparathyroidism, remember, in the distal convoluted tubule of the kidney, you'll bring back you'll bring back calcium and you will get rid of phosphate. That's a way of getting rid of phosphate, okay? But obviously you'll end up with hypercalcemia here, you may end up with kidney stones, whatnot. All right. What is this from? Oh, this brown tumor just is increased. Yeah, I feel like they mentioned this. Maybe it was a UWorld question. It's brown tumor. I don't know. All right, here's Paget's disease. Okay, so anytime they talk about somebody has a new hat size, I don't know why that's so important. I mean, it just means their head's getting bigger because it's getting deposited with more bone. So you have increased hat size. That their jaw may get a little bit bigger. That may be confusing because when they talk about a large jaw, sometimes it's increased GH. But when they talk about a hat size, their feet get bigger or stuff like that, it's usually Paget's disease. Now, as I mentioned earlier, there are these different phases to it: osteoclastic, mixed, osteoblastic. Okay, so but inevitably with the disease process, you're going to get these thicker bones. Okay, it's not a good thing. They're not like it's not like normal bone. Like if you looked at it, under a microscope, it's kind of this it's a good way of putting it, lack of structural stability. So they're prone to fracture. But they'll talk about this in regard to somebody had an increased hat size or something like that. Think Paget's, okay? Once again, the lab values, your calcium and your phosphate will be normal. The only thing that's elevated and diagnostic is your ALK-Phos, alkaline phosphatase. Alkaline phosphatase is a marker of increased bone turnover. Okay, right? Let me go back 1 second. Did they say it in osteoporosis? The lab values, I believe in osteoporosis, your calcium and phosphate are normal too.
Yeah, they're normal because it's a slow progressive disease.
Okay, and I don't think you get an elevated ALK-Phos there either. That's so all your lab values are normal in this. Okay, so if you're looking at that versus Paget's disease. Paget's disease, you're looking for that increased ALK-Phos. All right, let's see what else. Yep. Right, here we go. Oh, and this too. This is like urine hydroxyproline. That can show up in the urine. Okay, so serum ALK-Phos, urinary hydroxyproline. So a component of the collagen breakdown in the bone. All right. Oh, here's a good one. Because it's deafness too. And you know why? That's because in the skull, if you have increased bone deposits, it can actually cause stenosis of those little foramen that the cranial nerves come through. So it can actually pinch the cranial nerve. So that could actually lead to deafness. So one of those weird things you wouldn't think was involved but that's a good one, right? So deafness is compression here, you can see. All right, jigsaw pattern, another kind of buzzword. It's bowing. When you think of bowing, you think of rickets, but when this Paget's disease, you can see this as well, just because it's a disorderly deposition of bone. All right, can lead to sarcomas, osteosarcoma in particular. All right, renal osteodystrophy, right? So in chronic renal disease, you have trouble regulating all these, your calcium, your phosphate, and stuff like that, right? Dysregulation, specifically vitamin D. If you can't do that, you're not going to be able to transcribe calbindin from that active vitamin D. You're not going to put it in the GI system. You're not going to reabsorb, or you're not going to absorb calcium and phosphate from your diet, okay? So it can lead to secondary hyperparathyroidism. Why is it secondary? Because the primary cause is decreased vitamin D. Decreased vitamin D means decreased calcium and phosphate absorption, which means you have hypocalcemia, which signals to the parathyroid that you need to increase your blood calcium. So you get secondary hyperparathyroidism, meaning you're at that point where you need calcium so bad you're going to start pulling it off the bone. Okay, right, so that's not good. All right, rickets, you know that, osteomalacia rickets, pretty much same thing, just adults versus kids, right? And it has to do with mineralization, demineralized bone, okay, demineralized. A lot of the other ones have very fragile bone, but when you talk about mineralization of bone, this is very classic for these two. Bowing of the legs, y'all know that. Rachitic rosary is another one, these hyaline cartilage overgrow, so they talk about that. Pigeon chest deformity, lumbar lordosis, all of this has to do with the fact that you have very fragile bones that are demineralized. You can see this, look at the bowing of the legs here. All right, scurvy, you know that, that's vitamin C problems. Not only do you get gum issues, bleeding of the gums, you get these little petechiae. This has to do with very fragile little capillaries and little blood vessels there. So you can show that. I've seen that a lot of UWorld questions don't even mention the gums. They just mention this, and you're like, it could be anything. Anything causes those little rashes, but it comes to be out to be vitamin C deficiency. So be aware of that. Failed cross-linking of collagen, which is what you need vitamin D as a cofactor for. All right, let's see. All right, so that's about that. Again, most of that is review. Are we getting to the tumors? All right. And for better or worse, a lot of these tumors, it comes down to memorizing a few buzzwords for each. I think in real life, this stuff's super complicated, and they're kind of just introducing the stuff to us. All right, so I'll do my best here. Let's get to them. Right, I found this helpful, trying to isolate where they are, because they typically tell you, you know what it reminds me of? It reminds me of the brain tumors when they talk about infratemporal versus supratemporal, supratemporal being adults, infratemporal being kids. It kind of let me kind of separate all of the tumors of the brain, you know, by age, you know, by them just giving me the age. I can kind of do that. For this, a little bit more difficult, like giant cell tumors do move. But other than that, I mean, this is a good clue. If they tell you where it is, you can kind of eliminate some of the other ones. So good bit of memorization there, but it is what it is. But if that you think that helps you, then go for it. Osteoblastoma, I find is, no, sorry, it's osteochondroma that I'm thinking of. We'll get there in a second. All right, so we're kind of differentiating the differences there. I don't know, that's super important. Some of these buzzwords for reactive sclerosis, you can see there. Malignant bone forming. Yeah, osteosarcoma, that's the big one that they talk about. I believe it's the most common bony tumor. You can see these in teens, young adults, the metaphysis, knee and distal femur. They'll even give you that picture of it. Yeah, here it is. Let me go back. Make sure I didn't skip anything. But yeah, you can see this Codman's triangle, right? That's this increased angle here. That's very classic for it. Lytic lesions, meaning shoot. Lytic lesions, meaning it's pulling it off the bone, right? Wow, let's see. There we go. Let's make sure I didn't miss anything. Here's some pathology that goes with it. I don't know. Right. So, but if they showed you a picture of this, think these osteosarcomas. Now, it's very important to start doing it now. Lytic versus blastic. When you talk about stuff like prostate cancer, they're blastic deposits. When you start talking about things like multiple myeloma, they cause lytic lesions. So it's important now you start doing that. That's going to be important for staff going forward. So osteosarcomas are going to cause lytic lesions. So it's going to pull the particles of the calcium and stuff off the bone. And you can see that you get this elevated periosteum. That's another buzzword for it too. And like it said, younger than 20 years old, knee tibia area. That's what you're thinking there, osteosarcomas. Yeah. Chondromas versus endochondromas. Let's see if there's any big buzzword. Oh yeah, endochondromas are correlated with these. I think there's another slide that kind of differentiates these. But some of these, just don't, very low yield in my opinion. But maybe if you know some of the genes that are involved with each, you should be good to go. It does have a differential here in age. I can't remember a question about it off the top of my head. Oh, that's a good, interesting fact about it. These osteochondromas do cause this stalk formation. It's a very unique picture. So I'd say that's fair game there. And then endochondromas, you can see it at the diaphysis and metaphysis. Here's these different ones. So Ohlier's disease, if that's how you say it, you actually get these multiple endochondromas, but they tend to be unilateral. Mafushi's disease, you can get it bilateral, and you also get compilation of different things, hemangiomas, chondrosarcomas, and gliomas. So there's probably something wrong with like one of those big tumor suppressors like P53, being that there's so many different variety of tumors that form. So yeah, let's see. Yeah, so when you talk about metastasis for bone, typically these are hematogenous or through the blood spread to the lungs, okay? Since it's the cable system, not the portal system, and for the bones, it can get to the lungs easier, kind of bypasses the liver. All right, I don't know that this was really tested. Yeah, okay, giant cell tumors, epiphysis, increased expression of rank gal, so that's gonna overactivate those osteoclasts, as you can see here. Yeah, oh yeah. This is important. Yeah, that's a very characteristic picture. This soap bubble appearance, okay? You can see that here, destroys the overlying cartilage. Yeah, so for those giant cell tumors, that's a good picture. I believe I've seen that before. Okay, so make sure to know that. Ewing sarcoma, yeah, I forget there was something important about it, maybe. Doesn't it have something to do with 22? Is that it? I think that was Patrick Ewing's number for the Knicks. He was number 22. That's how people remember that. Right, onion skin appearance. There you go. So that's another one. If you're writing down just quick notes, onion skin appearance is a big thing for these Ewing sarcoma. Find it in diaphysis. You find it in kids. So that's a good way to remember that. Homerite rosettes, those are found in a lot of different places like neuroblastoma, medulloblastoma, but that's another characteristic that you can see here. Multiple myeloma, you've learned about this. You get this monoclonal IG spike, usually IgG. Binge-Jones proteinuria, you get these Binge-Jones proteins. That's another buzzword for it. And as I said earlier, look at these lytic lesions. You can see them all over the place, okay? And you could find those there. Right, and then when we talk about metastasis, remember blastic, things like prostate cancer, it can spread directly to the vertebrae because of the proximity to it. So you'll get these deposits versus lytic lesions, which are punched out lesions. And then there's some good mnemonics here for kids versus adults. Okay. Yeah, so as I mentioned, the tumors do get complicated, but I think you can get away with knowing just a few buzzwords for them. You should be good. When in doubt, go with osteosarcoma. That's, you know, if the person's under 20 years old, just because that's the most common. All right, what's this about? Joints. All right, yeah, you know the joints already. We'll go through this quickly. Inflammation, worse in the morning. You're typically talking about some sort of rheumatoid arthritis, right? Inflamed. That's typical for rheumatoid arthritis. Yeah, hypersensitivity reactions. Okay, so well, first osteoarthritis, degenerative, meaning it's worse. It gets worse in the evening, worse with use. Okay, so weight-bearing joints, typically older people. Narrowing of the joint space is very characteristic of it. Yeah, narrowing, you can see here. So you don't get inflammation. So technically, like things like ibuprofen or stuff like that aren't really going to help, because that's basically based around the principle of inflammation. Okay, so some of the things that are characteristic, ubernation, that's how you, yeah, I think that's how you say it, right? Which is like the smoothing over, a subchondral sclerosis and some subchondral cysts that can form there. And then osteophytes, there's a very characteristic of that too. Those little outpouchings of bone, or little jarred edges of bone, right? But these should be pretty straightforward. You know, they usually tell you the patient wakes up, it's worse in the morning, worse in the evening, stuff like that. So RA is a autoimmune problem. Then you can see, so it's inflammatory, so it should be worse in the morning. It's relieved by ibuprofen or NSAID, stuff like that. Typically involves the PIP and the MCP joint, whereas osteoarthritis is typically the DIP. Okay, so keep that in mind. Rheumatoid is usually the PIP and MCP joints. All right, now you get this pannus formation as well. It does, be careful. It says it's a type 4, but it is also a type 3 reaction. You get antibody antigen deposits as well. So it can be both. Osteoclast activation, but again, this is an inflammatory process. So you see cytokines, you see this pannus formation. This is this pannus formation, but again, it's an inflammatory reaction. So you should be able to pick that up. Right. Morning stiffness, that's a big one. 1 hour, then it gets better. That means it was inflamed, and then as you worked it out, kind of stretched it, it got a little bit better. All right. Right. So ulnar deviation of the hands, that's characteristic of it as well. So here's a good differential. Weight-bearing joints, look at this narrowing of the joint space. Rheumatoid arthritis, you see this pannus formation. So you can appreciate that there's inflammation going on there. All right, and then we have our seronegatives. When I hear seronegatives, the first thing that pops in mind is B27. They're all associated with B27. If you get in there in the stem of the question and it says B27, you want to jump directly to these, okay? They kind of all go together in my brain. Ankylosing spondylitis, typically that is the area of the lower spine, the lower lumbar region. You get kind of fusion of that area, so you get decreased range of motion of the axial spine, large joint space. You can see that there. Reactive arthritis, remember the bugs that cause it. Usually they're GI bugs, Salmonella, Shigella, Yersinia, Campylobacter, but don't forget chlamydia can do it too. Can't see, can't pee, can't climb a tree, okay? Or can't bend the knee. There you go for your Game of Thrones fans. All right, psoriatic arthritis mimics RA, but you can see it in a DIP joint. Characteristic, probably a small fact to know. Spondylitis is there too, but you would expect to see signs of psoriasis, extensor surface of the arm, hyperkeratosis, perikeratosis, you know, all of that excess skin that's there. And then, yeah, that as well. All right, let's see. That was the first section I wanted to go through. What time is it? 11:09. Let's do the P stuff real quick. Yeah. Then we'll take a break, and then we'll look at the drugs and the HIV stuff. All right, so hopefully this is a good bit of review as well. So, right. Review birth injuries, right? You know this. No, these were those different ones. So I'm not going to try to say that. Swelling of the scalp, right? That's very superficial. Cephalohematoma is blood under the periosteum, right? So you know that. Facial nerve palsy can happen if you need to use the forceps. Okay, so yeah, but cephalohematoma is a little bit lower. That's how you can know that. I don't think we have a question on that or anything, but yes, of course, 3 to 8 weeks, 3 to 9 weeks, whatever they say. I think first aid says 3 to 8 weeks. Very important. A lot of things growing. Very susceptible to teratogen, specifically that 4th to 5th week. 4th week is when the heart starts beating and stuff like that. So, right, some of the very important things, you definitely need to know that. Thalidomide, not really used too much anymore, especially, definitely not for pregnant women. You can get limb malformations, failure of limb growth, about fetal alcohol syndrome, microcephaly, maxillary hyperplasia, stuff like that. Nicotine exposure, typically nicotine is a vasoconstrictor, so you can get low birth weight and stuff like that due to the vasoconstriction, lack of blood flow and nutrients. And then my maternal diabetes is the opposite. That's where you get fetal macrosomia, all that extra glucose floating around, baby eats it up and it gets really big. Okay, so they could be at risk for a lot of different things, but the big thing is that macrosomia that forms. All right, know about Down syndrome. We don't really need to get into that. Just remember that people with Down syndrome have a high risk of these cancers, ALL, AML, but also remember the Alzheimer's disease, the APP gene for Alzheimer's is found on chromosome 21. So having that trisomy there does give you risk for it. I think congenital heart disease is kind of all over the place. They get that intraseptal heart problem. I can't think of the word for it. It's the septum that gets messed up. So you can be prone to like not endochondrial. Anyway, I think it starts with the E, but you're prone to VSDs and ASDs and stuff like that with these Down syndrome. Kids, Turner's. Also with Down syndrome, you get duodenal atresia. That's another big one. Oh, here it is right here. Okay. Atrioventricular septal defects. I think there's another word for that though. It starts with the E, but I can't think of it. All right, Turner syndrome. Remember, girls web necks. 45. You don't have the other X. So you get coarctation of the aorta. That's a big one, meaning that you get decreased amplitude of the pulse to the lower extremities. The coarctation comes off after the blood has gone to the head and the arms. And then the coarctation is like a pinch point, meaning you get decreased blood flow to the lower limbs, okay? So you get very high pulses to the arms, low pulses to the legs, web neck, that's a big one. Bicuspid aortic valve, if you know that, you should be able to get all the questions right. Oh yeah, streak ovaries as well, right? So 1X, you don't actually make ovaries, proper ovaries. They'll tell you it's fibrotic or something like that. They may not say streak, but this leads to infertility, amenorrhea, stuff like that. Klinefelter's XXY. So big, tall guy with female characteristics that's formed male hypogonadism as well, gynecomastia, euchinoid body habitus, meaning they're kind of tall, but you could see that they're at risk for breast cancer and stuff like that, okay? So, yeah. All right, and of course, about the DiGeorge syndrome, catch-22. You could have this velocardiofacial syndrome that's kind of coexisting with the DiGeorge syndrome, so some of these facial abnormalities that can develop as well can form, but it's basically just a deletion on the 22. Remember catch-22, that arm. Thymic hypoplasia, specifically teeth cell impairment. You don't have parathyroids as well, so you get hypocalcemia, you can't make PTH, and apparently it leads to psychosis too. There you go. All right, and some errors, right? These are kind of just buzzwords. Malformation is intrinsic, deformation is extrinsic. Whatever you need to do to remember that, that comes up on these UWorld questions too, and it's a pain because you're like, I did know that at one point. Deformation extrinsic, right? So if the baby's deformed because there's not enough amniotic fluid or whatnot, you kind of, they come out with, the foot malformations or whatnot because they've been kind of jammed in for lack of a better term, in the amniotic fluid. And malformation is intrinsically, so it's a problem with the developmental process. Disruption is something that is a factor, extrinsic factor, destroying something. I think the one they use for that is if there's like a fibrotic band that wraps around, it can like pinch off the arm, the blood flow to the arm, and you can get loss of a limb that way. So here's malformation, right? So malformation, as we said, is an intrinsic problem, okay? Error in morphogenesis, intrinsic problem. So you could see polydactyly, cleft lip, ASDs, anything intrinsic, right? Deformations is extrinsic, so small uterus, stuff like that. Oligohydramnios is a big one, just very constricted space. And then a disruption, as I mentioned earlier, these amniotic bands that can form can cause decreased blood flow leading to ischemia. You can lose a limb or whatnot. A sequence is something that happens in order, right? So it's one initial cause that leads to a bunch of different things. So Potter sequence is the big one. You have renal agenesis. So because you have renal agenesis, you get a bunch of different things. Now, remember that if you don't have the kidneys, the baby is able to swallow the amniotic fluid, which is fine. The baby just can't pee it out. So you end up with oligohydramnios because the baby has it in her body, but isn't able to get it out. So you have decrease. And because of that, because you aren't able to pee it out, you have a bunch of different things. Remember that process of cycling through the amniotic fluid helps to develop the lungs. So you get pulmonary hyperplasia. You may get some sort of deformation. Look at the feet. Maybe the baby was constricted in there because of the lack of amniotic fluid. So stuff like that can lead to it. But the point is, it's a sequence. It's one thing that led to a bunch of different other things. Okay, and then malformation syndrome. Right. So no single, what was that called? Malformation. Okay, so something, no single problem that initiated it. It just seems chronological. I don't know what they're getting at there. Presence of one or more developing abnormalities and two symptoms. Okay, so it's not necessarily a sequence. Okay, it's just kind of something that goes together. Maybe they're close together on a chromosome or something. It's in simultaneous involvement of different tissues. It's not necessarily a sequence. Okay, great. Maybe that's like Vactral. Maybe that's a good, the Vactral, maybe one of those where they're not all really together. They just seem to be a bunch of different things that happen together. I don't know. Maybe you want to double check that. All right.
So it's supposed to be like a defect that's like caused by the same thing, but they're not like related. So they happen because of they don't cause each other, but they're because of like the same like chromosomal deletion kind of thing.
Okay, yeah, that makes sense. Right. So you want to compare that versus something like a sequence where the kidneys were affected that led to everything else. Okay, that makes sense. Thank you. Or like I think maybe another word for that is an association. I'd have to double check, but I think back in FDM, we went into that in a little bit more detail, but if this is in your notes now, that's all you really need to worry about. All right, congenital infections. These are just ones you really need to memorize because a lot of them have very similar characteristics. A lot of them show up with eye problems. A lot of them show up with sensory neural hearing loss or congenital heart disease. So you just need to remember which ones go with which. All right, rubella is a big one. Mom needs to be vaccinated. Otherwise, it's risk. The mom really is not going to get a lot of symptoms from rubella. It's just the child that's going to get the problem, right? We talked about with cat feces, toxoplasma there. So yeah, let's go through these and I'll point out some of the very characteristic ones, right? Torches, that's the big one. That's how you remember what goes with what. All right. So these herpes viruses, CMV falls under the herpes virus. Sensory neural hearing loss is the big thing there. I'm pretty sure you get eye problems as well. Well, you get blueberry muffin rash, hearing and or vision loss. Okay, so CMV is one that has hearing and vision problem. Okay, sensory neural hearing loss. I think, yeah, and you get that chorioretinitis, I believe, as well with it. And you can see some of the other ones. Be careful, this blueberry muffin rash is not specific. There's some other things that can lead to that as well. Yeah, oh, I wrote it in here, chorioretinitis. So, so CMV, eyes and ears. Keep that in mind. And we'll look at some of these other ones as well. Oh, here's an important point. If the mother's infected during pregnancy, typically when you get that primary infection, it's a lot worse because your body hasn't built up an immunity to it yet. So if the mother's infected during that first pregnancy, I'm sorry, if the mother's infected during, like if the initial CMV infection is during the pregnancy, right? Maybe that first trimester, as it says here, it's very problematic. Okay, so the mother hasn't developed antibodies to it and whatnot. All right, yeah. So a lot of different places you can get that, which is important to know. All right, transplacental makes sense. All right. Okay, microcephaly, that's a big one because with toxoplasmosis, when you're comparing these, you can get macrocephaly, I believe. I think you can get also increased intracranial pressure. So that's one of the differential here. Another big one is that you get calcifications. Now with CMV, these calcifications are around the ventricle. With toxoplasmosis, you get diffuse calcifications. Okay, so another one, where now we say again, CMV has eye problems, chorioretinitis, ear problems, sensory neural hearing loss, microcephaly, can even get hepatosplenomegaly. That blueberry muffin rash is not specific, but again, I want to point out that these calcifications, they're going to tell you, they have to tell you if they're diffuse or paraventricular, or I show you a picture, because otherwise you're kind of in the air about could it be CMV or toxoplasmosis. All right, so what we got here, rhinitis, rash, maculopapular rash, stage 2. Okay, so maybe this is, oh, yeah, syphilis, yeah, good. Okay, so, right, so you can lead to the syphilis you initially get this painless canker, right, this condyloma lata, and then it can develop, once you develop the rash, you're officially in the second stage, and then you can go to tertiary syphilis, which is where you get a lot more of the neurologic problems, and you're at risk for transmitting it to the baby as neonatal syphilis is the word I was looking for. Right. So here, syphilis leads to sensory neural hearing loss. No eye problems, okay? So again, CMV, eye and ear, syphilis, just ear, spares the eyes. Some of these other ones, don't bet on UWorld just giving you these easy words because you'll know it right away. Hutchinson's, incisors, Sabershins, they're not going to give you that. They're going to want you to be able to differentiate it with some of the more common overlapping things. VDRL is how you're going to diagnose this, right? Okay. Good. Right, but ideally the mother's tested, tested for syphilis, very easily treated. I used to, when I worked at the hospital, these moms would come in down in New Orleans, and we treat the syphilis, and they come back with it, and we'd ask them if they got their partner treated, and they say no, and we'd be like, you need to put it in their food or something. I don't know. You need to treat your partner, otherwise you're going to keep getting it. But it's so easily. The point is, it's so easily treated. All you need is penicillin, so you don't want your baby to catch it. All right. So Toxoplasma gondii. Remember cat feces, inhalation. Now you can see this diffuse ring-enhancing lesions. When we talk about CMV, there are periventricular calcifications. Here you see this diffuse lesions, these ring-enhancing lesions, okay? Chorioretinitis, very similar to CMV, diffuse intracranial calcifications, and hydrocephalus. Hydrocephalus means, the head's gonna end up being, macrocephaly because the sutures aren't closed. Okay, so chorioretinitis, very similar to CMV. Toxoplasmosis has diffuse intracranial calcifications, where CMV has periventricular calcifications. Toxoplasma can lead to a big head. CMV can lead to microcephaly or a small head, okay? So keep those in mind. They like to try to get you on those. And look, you can even develop cataracts with CMV. When I think of cataracts, I really think of rubella, but it says here that that's a thing. Okay, anyway. Let's see. Okay, rubella, big one. Mom needs to be vaccinated. If they ever say, this comes up in the questions too, kid comes in with these symptoms, you're like, that must be rubella. What is the number one thing that could have been done to prevent this? Mom being vaccinated is it, okay? Now, again, cataracts is this. So you're not getting that chorioretinitis. This is full-blown cataracts that you could form. PDA is a big one that you get there. Okay, so if you have a PDA, that's the one that's a machine-like murmur all the way through systole and diastole. So a continuous machine-like murmur. Remember I said, be careful with those blueberry muffin rashes. They're not really specific, okay? Right? This crosses the placenta. So that's a problem there. Okay, so that's all they really gave us. Oh, sorry, I missed that one. So again, very similar to CMV, you get eye abnormalities, except in CMV, you get chorioretinitis. In rubella, you get cataracts. Sensory neural hearing loss, very similar to CMV as well. And you can see here that with toxoplasmosis, it spares the ears. Okay, so let me just reiterate that again. CMV, ears and eyes. Toxoplasmosis spares the ears. Rubella is ears and eyes. Okay, so if you want to write those down, that would be a good thing. So you can see here, rubella, eyes, cataracts, and ears, sensory neural hearing loss. Because a lot of times it comes down to one or two of those little things that can differentiate it. And what did we say for, we did syphilis too. Which one was syphilis? Syphilis had sensor, so it spares the eyes, okay? Sensory neural hearing loss. Okay. So toxoplasmosis spares the ears, syphilis spares the eyes, CMV has both, rubella has both. All right. Good. That's literally how I have to do it in my head to keep these straight. All right, Zika, not super important. Microcephaly, sensory neural hearing loss as well. Nah. Yeah. I don't know. Some of the treatments you can give. CMV, remember, you don't want to give acyclovir. That's for HSV. Give ganciclovir or valganciclovir, which is a precursor to it. Rubella, obviously, you want the mom to be vaccinated there. Syphilis, just penicillin. Toxoplasmosis, pyrimethamine or sulfatazine. Whoops. Yeah, that right there. All right, good. All right, two more and we'll take a break. What are we doing? Premature birth and complications. All right, so again, this is kind of review for you guys. Remember, premature around 26-ish weeks, we're making surfactant, enough surfactant to live. That's gonna be the big problem here. But let's go through these first. We talked about the torch infections. Placenta previa, I think a preview, like if the placenta's over the entrance, you know, and if the doctor's looking through the cervix, you can't see the amniotic sac, right? It's preventing the preview of the baby. That's how I remember that. So that means it's over the cervix. Placental abruption, depending on the degree of abruption, you know, you can get this intrauterine bleeding, and it could be a problem for the baby, depending on it. So usually they'll talk about some sort of trauma, some sort of car accident. The pregnant mom comes in bleeding, and you're kind of worried about that. So you need to check that out. Preeclampsia always comes up in these questions. Remember, you're looking at hypertension, nuance at hypertension and proteinuria, okay? It can lead to eclampsia. If that's the case, you're worried about seizures and stuff like that. Okay. APGAR score, I think this is more for your OSCE than for this test. Okay, so hyaline membrane disease, respiratory distress. If the baby is born prematurely, you don't have enough surfactant. Okay, so that's a big problem there. If you know you have to deliver the baby prematurely, you can give the mother glucocorticoids or corticosteroids, and that will help to stimulate surfactant production. Okay, so if you can do that preemptively, that'll help with this. So this respiratory distress syndrome. Now, some of the complications that develop from respiratory distress, not only hyaline membrane disease, which is the primary problem, but you can get some other things. So one of them is this necrotizing enterocolitis. So it's tissue destruction of this small and large intestine. Okay. And there's a few other ones that they talk about that we'll look at too. Hyaline membrane disease is one of those things. Again, this is not specific. There's some other things that cause this ground glass appearance, but hyaline membrane disease is one of them. Okay, so diffuse alveolar damage, premature infants, we're thinking surfactant deficiency. All right. Oops. Right, so here we go. So these are some of these complications that can happen. This retrolintal fibroplasia, bronchopulmonary dysplasia, and specifically when these kids come in respiratory distress, you need to give them, 100% oxygen, ventilator-assisted oxygen to prevent the alveoli from collapsing, positive pressure oxygen. So this could lead to these problems here as retrolingular fibroplasia, bronchopulmonary dysplasia. So if this oxygen toxicity can cause this on the infant, leading to blindness. It's specifically related to VEGF. Okay. Now can also get this bronchopulmonary dysplasia if you can kind of back off of the positive pressure ventilation and give surfactant. You can help with this, but because these lungs aren't really developed, they are, at risk for this with all that positive pressure oxygen. All right. And then, as I mentioned earlier too, necrotizing enterocolitis is a problem. Second to third week that can happen. And then intestinal ischemia is what you're thinking about because the baby wasn't able to breathe properly with the surfactant deficiency, bacterial colonization, and even formula feeds, which is one of those unique characteristics. So if they talk about that, maybe that'll clue you in. So, all right, yeah, abdominal distension. You would expect bloody stools can lead it can lead to shock, even DIC. Okay, and then gas in the intestine, pneumonitis intestinalis. You can see that here if it's a transmural and air gets out from the GI tract from the necrotizing or the necrosis, right? And you can see that here. So if it's transmural and it goes through, you can get air in the intestine or out in the abdominal cavity. All right. Right, talked about that. Wait, actually, yeah. Okay, intraventricular hemorrhage, right? So bleeding into the germinal matrix, that's right around the ventricles, right? So if you get blood there, the patient may present with increased intracranial pressure. Sutures haven't closed, maybe it's a macrocephaly, but you can look in there and if you see this hemorrhaging, you're expecting from this germinal matrix, these little fragile vessels that are around the ventricles. Okay, so be careful with that. So you're thinking increased intracranial pressure, macrocephaly, and bleeding into the brain, specifically around the ventricles. And good. Okay, hyperbilirubinemia. Yeah, we talked about, well, y'all remember this from, I guess, term 2, increased bilirubin production. So when we talk about prehepatic jaundice, remember it's primarily due to hemolysis. And so red blood cell breakdown, whatever's causing it, whether it's some sort of autoimmune problem or whatnot, increased red blood cell breakdown, hemolysis can lead to increased bilirubin, increased unconjugated bilirubin in the blood. And then if there's defective conjugation, that's a problem with intrinsically in the liver. And you can I don't assume kids really get kidney stone. I'm sorry, gallbladder stone. So I don't know that you'd really worry about too much of that post-hepatic jaundice. But remember, if you can't conjugate the bilirubin, you can end up leading to kernicterus, those deposits in the brain. Hold on one second. Those deposits in the brain can lead to, in the basal ganglia, can lead to different sorts of neurologic problems like movement problems in the basal ganglia, and even psychological problems as well. All right, so, right, let's just go through these quickly. Right, this is the enzyme. What's the big word for it? I'm sure it says it somewhere. Uniglutal, I don't know, I don't remember. Right, so that takes a little bit of time. So you can get neonatal jaundice, and you can use those lights, those UV lights, phototherapy with blue lights to convert it to bilirubin or conjugate it that you can excrete. But this enzyme is what's defective or not developed yet in these kids. So that's just pathological. Usually it's not a big deal. Okay, so if you do get some sort of hemolysis, you could get prehepatic or unconjugated bilirubinemia. Erythroblastosis fetalis is that Rh problem. If you have, the mom has Rh negative, y'all remember this, mom's Rh negative, and she develops antibodies in her first pregnancy, and the second baby comes out Rh negative, her antibodies will attack their red blood cells in the second baby, and this is very dangerous for the baby. All right, so you would expect these prehepatic jaundice due to destruction of the red blood cells. All right, lead to hydrops fetalis, death in utero, and then kernicterus is this bilirubin encephalopathy, this unconjugated bilirubin that gets deposited in the basal ganglia. You can see that over here, these little yellow spots. All right. Yeah, Coombs test is always looking for some sort of autoreactivity to red blood cells. So some sort of autoimmune problem. You can check that to see if there's some sort of problem. You can check to see if there's autoimmune hemolytic anemia going on. All right, now we're looking, oh, there it is, UDP glucuronoltransferase. That's the enzyme. Remember, Crigler-Najjar, type 1, type 2, and Gilbert syndrome, however you pronounce it, is just a spectrum of this deficiency. So type 1, UDP glucuronoltransferase is like less than 5% of this enzyme, so it's really bad. Type 2 is, I guess, 10 to 20%, so it's a little bit less. You could treat it with phenobarbital to help regulate this enzyme. But the point is, without this enzyme, you can't really conjugate bilirubin because that's the enzyme that ends up doing it. All right, and then there's all, well, I guess they don't talk about it, but okay, anyway. Biliary atresia, so if there's some sort of blockage there, complete obstruction, that's going to be a problem. You're going to need to fix that surgically. Let's see what else. Neonatal hepatitis. Okay, I don't know that that's a super high yield. Dubin-Johnson, that's the other one. Remember, this is a problem in the liver. It's conjugated liver. They call it the black liver. It's a problem with the ABC transporter, transport of conjugated bilirubin. Okay, so that's the one disease that you're worried about with increased conjugated bilirubin. All right, you can see this black liver, and actually that's actually a testable point because it's weird. Like, I don't know why these polymers, this black liver, is actually epinephrine metabolites, not bilirubin. Okay, so make sure you make a note of that. I don't know when I saw a question on it, if it was the test or more recent, but epinephrine metabolites, that's what these black deposits are in Dubin-Johnson syndrome. Rotor syndrome, I don't even remember what this is. I don't know. I don't think it's very high yield. All right, and then everybody knows about cystic fibrosis. Right. Okay. Good. Yeah. There was a DLA. I didn't pull this one out, but it would, remember with galactosemia, there's two different forms. The bad form you can get within 2 weeks. You get those cataracts, you get hepatomegaly. So it's really bad. And PKU, y'all know, mousy or musty body odor. You can't break down phenylketones and right. So you have to supplement with tyrosine and stuff like that. Okay, I need a little bit of a break. maybe like 5 minutes, and then we will go through some of this multi-system stuff, the HIV stuff, and then I'll touch on some of the drugs for you guys. All right, so we'll take a 5-minute break. All right, if you guys are ready, we'll try to knock this out real quick. Let me share my screen. All right. Go through some of these. Let's see. Right, okay, good. Some of these are very similar, these vector-borne diseases and stuff. There was a couple of things that were testable, but these slides were a little convoluted. So just knowing a little bit, the cause of the vector, right? Mosquitoes involved, and then some of the specific characteristics of each that will differentiate them. So let's see. Yeah, here we go. Some distinguishing features: yellow fever, liver, kidney, heart, and hemorrhaging is the big one there. It causes jaundice, and black vomit is a big thing they talk about there. Dengue, break bone fever, pain behind the eyes is a big one there. Zika is a milder disease, and chikungunya, I think they really talk about really bad joint pain with that is the one that stands out. But more testable for these SGU tests right now than really for STEP or anything. But yeah, we'll go through it. I believe are they all single-stranded? Yeah, all single-stranded RNA positive icosahedral envelope. You could run a PCR to figure it out. All right, so here we go, yellow fever. It's where you primarily see it. So look for recent travel. Right, local lymph nodes, blood-borne macrophages, Kupffer cells. Remember, get that liver injury, looking for that black vomit. These councilman bodies is very characteristic for yellow fever. So keep that in mind. Gastric mucosa, black vomit as well, okay? Big one here, there's a few things that can cause it, but when you have fever, you would expect to have tachycardia. So if there's relative bradycardia, that's one of those weird things that's characteristic. I think leishmaniasis is another one that causes that. You get this period of remission, but specifically you're thinking about jaundice, hemorrhage, and it can lead to multi-organ failure. So remember that black vomit is characteristic for yellow fever. Dengue, right? So that's a thing in the Caribbean. You need to worry about the same bug that you're worried about, that mosquito. Right, same thing, macrophages, target cell that you can get there. But we're talking about here more of this, this breakbone fever. Here's a very important point. So what ends up happening is you get infected with dengue fever, and then so you develop antibodies against it. But then the second infection is dengue fever as well, but it's a different serotype. So it's slightly modified, it's slightly different. And what you end up getting is there's a cross-reactive antibody effect. So your second encounter is much worse, okay? So, and that's because you've developed antibodies. I almost think of it, you know, they're very similar to each other, like a brother-sister. So you developed antibodies to the brother, and then the sister came along, and you kind of have antibodies to the brother, but the sister's different in a little bit of, you know, a few ways. So because of that, your body doesn't know, and it kind of freaks out because it's close but not exact. And then you end up getting these harsher symptoms because of it. So that's called antibody-dependent enhancement. Okay, so that's definitely a testable point, specific for dengue. Now, right, what does it say? Right, so this can also happen in kids, because if a baby gets passively acquired antibodies from the mom that last, I don't know, maybe 6 months, and the baby gets an active infection, right, that acts as that second infection if it's a different serotype. So the baby can get it very bad. So be careful with that. Now, breakbone fever plus pain behind the eyes. Those are going to be characteristics of that. So you still get the hemorrhaging, you still get blood, you still get liver problems, but you're worried about this breakbone fever. That's going to be a characteristic. Look at that rash. Islands in a sea of red, so it's very intense maculopapular. Right, tourniquet test. If you do the tourniquet test, that's specific for it, and what you're actually causing is these little micro hemorrhages there, capillary fragility. So that's another testable point for dengue fever. Zika, not as bad, but was very virulent back in the day. Again, same positive sense, single-stranded DNA. Right, mosquito, you can get it many different ways, as you can see here, which is why it was so prevalent. Yeah, so this would, if anything for Zika, I would say that this would be testable. Body fluids, look at that in your tears, saliva, everywhere. So, and you can also vertical transmission as well. All right, defining thing that kind of stands out here is the conjunctivitis. Okay, so you get Zika, again, rash, palms and soles, that's a good characteristics as well. But if you're looking for the conjunctivitis, that should be in the stem to help you differentiate it. All right, you could lead to Guillain-Barré syndrome, even microcephaly in the baby. But again, this is a post-viral thing, usually a GI infection, but Zika can apparently lead to it as well. Chikungunya, also positive sense RNA. Here, I think the big thing I tried to remember is that 90% joint pain. So, right, saddleback fever, meaning kind of relapses and remits. So you get the saddleback fever, comes and goes, but joint pain in 90%. So if we talk about joint pain, maybe lead to the chikungunya. All right. That should be about it. Yeah. Here's a good one. Yeah. So black vomit, right? Yellow fever, dengue, breakbone fever. It has that antibody-dependent enhancement with those different serotypes. Zika, rash, and palms and soles can be transmitted a lot of different ways. Add in here the conjunctivitis as well. Chikungunya, saddleback fever, also high prevalence of joint involvement. There you go. All right. Right, so schistosoma, whenever I think of that, I think of liver issues. That's the main thing to remember for STEP. As for your exam, maybe a little bit more detailed than that, but you can see in these different forms that it inoculates. Different ones, you know, I remember studying for this test, trying to remember all these, going through the different ones. I'm not sure they're really tested on that component, but I suppose it's fair game since it got brought up a bunch. Infected snails, they can get it and transmit it on. This is the one, right? I was trying to differentiate these. So the schistosoma with the H, hematobiome is in the urine. The other two are in the stool. So it's, remember that. That's a good way to keep this one. So the one with the H is in the urogenital tract. And then you can see you get a rash, itchy skin, fever, muscle aches, stuff like that. But the big thing is that it affects your liver. That's the big one. Maculopapular eruption, it can even lead to pneumonia. Stage 2, get this specific fever. Intestinal pain, here it is, it's the liver enlargement, accumulation of fluid in the vessels, enlargement of the spleen as well. Chronic syndromes, granuloma formation, hepatosplenic inflammation, liver fibrosis. So one of those weird things, I'm pretty sure, I'm not sure if it says it in here, it's one of those weird things where a parasite could lead to increased incidence of cancer, right? So because it affects the liver, it can lead to hepatocellular carcinoma. Pretty sure that's the case. You might want to double check me, but I'm pretty sure that's right. Right, so you can even get some sort of, in the bladder, obstruction of the bladder or the ureter, which can lead up to hydronephrosis as well. So it's pretty bad. You just want to make sure you address it early before it gets to the later stages, right? And you can see the occlusion of the ureters. Anytime that happens, you get fluid, urine backed up into the kidneys. Okay, not good. And then diagnostically, you're looking for those eggs. Yeah, no, I'm not even. Well, we know about Candida, but we don't really talk about this specific albicans is the big one. Remember, it's Candida albicans. I said classically pseudohyphae. Whenever you see pseudohyphae, albicans, but by all means, this is by far definitely the one you need to know. I don't remember them testing on anything other than that. Right. All right. Yeah, so then we have our Rocky Mountain spotted fever and our Lyme disease. Right, so yeah. Right, so typically hiking, get these little ticks that can get on your skin. If they stay there long enough, you could end up with it. Some good differentials. Remember, you get that bullseye rash with Lyme disease, maculopapular rash, or petechiae with Rocky Mountain spotted fever. Different ticks that can cause it, right? These Rocky Mountain wood ticks, brown ticks, dog ticks, yeah. So technically gram-negative rods, you could use gem sustain. Yeah, let's see. Hypotension. I'm trying to look for things that really stood out for me when I was doing this. Again, if you're differentiating, you're hiking and stuff, the rash is going to be important, maculopapular versus the target rash. But you're going to get a sudden onset fever and headache here and get that maculopapular rash as well. It could lead to conjunctivitis, muscle pain, and GI symptoms. Yeah. Complications leads to vasculitis. That's a good one to know. Digital necrosis and amputation. Okay, versus Lyme disease is more of a neurologic problem. You can think of Rocky Mountain spotted fever as more of a vascular issue. All right, and then, yeah. Then you get to Lyme disease. Hopefully, remember, that's one of the spirochetes, sort of like syphilis, leptospirosis. It's one of those spirochetes, right? So won't stain very well. I mean, you'll need to use like a Gemstar right stain or do one of these sorts of triple stains. All right, so again, it's from the vector. You can see the area here in the mountainous area, Appalachians up to the northeast. They don't really test too much on the life cycle. But again, neurologic problems, if it gets bad enough, you get this bullseye rash, erythema migrans, okay? Bullseye rash, facial palsy, Bell's palsy. A lot of times you get arthritis. So Rocky Mountain spotted fever, think vasculitis. Lyme disease, think neurologic issues. There's the bullseye rash you can see there. Flu-like symptoms, arthritis, and then of course it can progress to CNS disease if it's not treated. All right. Again, just like Rocky Mountain spotted fever, you kind of diagnose it by the rash or the clinical symptoms that you see there. Actually, I feel like this was tested. Just you do a two-tier test. Again, you think clinical suspicion, you could start treating it, but this is how you would do it classically. You need a two-tier test. So the first test is going to be like EIA or enzyme immunoassay or immunofluorescence. And then if it's positive, you go on to a second test where you could use a Western blot. Okay, Western blot is for proteins, technically, antibodies for proteins. Okay, so you do an immunoassay, and then secondary test or the confirmatory test, you'd want to use some sort of Western blot. Okay. Yeah, and then these actually have to stay in your body for like 24 hours. So the idea is after you go hiking to check yourself everywhere, have someone check you to make sure you pull these out. You don't want to leave the little head in there. So you have to pull it out correctly. Otherwise, it can keep injecting the bacteria in there. All right, leishmaniasis. Here's another one, sandfly. That's a good thing to remember there. Protozoal parasite. Again, they really don't test too much on the stages. All right. Right, and then we look here, reticular endothelial system. So you get these infection of the spleen, liver, and bone marrow. Okay, undulating fevers, right? So it goes up and down, time frame, you'll relapse and remit. Right, hepatosplenomegaly, it's a big one there. You can see how large this kid's stomach is. Hemorrhage as well, right? So, and it could lead to these gnarly rashes and skin lesions. All right. Yeah, so keep that in mind. Yeah, I would, if you want to look at these, it may be better to just kind of look at first aid. I think it's very concise in there. Now, African trypanosoma cruzi specifically is the African version, right? The reduvid bug, kissing bug, Chagas disease is what causes, is the disease that forms. Remember, this is African versus the South American one. Multiply in your plasma blood, right? Skin lesion, purplish swelling of the eyelid, you can see here, kind of more non-specific signs that could happen. But the big one is it can lead to dilated cardiomyopathy, okay? So Chagas disease, you're worried about dilated cardiomyopathy. That's the big one here. You can see dilated heart doesn't pump well, dilated esophagus or colon. So Chagas disease, think dilated, everything gets dilated, and that's gonna be the characteristic testable thing. Yeah, and this showed up as a UWorld question, so take a snapshot of that, what that looks like. All right. Is this more, there's just a continuation, okay. Wait, hold on. Did we just do the South American one? Chagas disease is South American, did it?
Yes, you just did the South American one, the Chagas.
I thought it said African on the top of the slide, but okay, so let me correct that. The dilated cardiomyopathy, Chagas disease is the South American trypanosoma. That causes the dilated cardiomyopathy. That causes the dilated esophagus and dilated colon. So South America, Chagas disease. Keep that in mind. Now we'll look at the African one. Now the African one comes from the tsetse fly, trypanosomas. So you get African sleeping sickness with this one. Okay, so the other one was South American, not African. Okay, and then these are some of the different reservoirs that you can find here, and then you can see the different locations that are found. I don't really remember if this was a testable point. Yeah, African sleeping sickness. So that's what you're really worried about with these. Versus Chagas disease is the dilated cardiomyopathy. All right, again, tropomastigote, you can see there. All right, here we go. Okay, so yeah, you can see here, Trypanosoma cruzi, Chagas disease, kissing bug, the reduvid bug. This is South America. Trypanosoma brucei, Rodentia and Gambisi, African sleeping sickness, the tsetse fly. Okay, so make sure you take note of that. I said it wrong earlier. And then leishmaniasis, cutaneous, visceral leishmaniasis, okay? The sandfly is the vector. Tularemia, you get that from rabbits. You can see there, gram-negative coccobacilli. Rabbit fever is a big one. Other than that, I don't know much about it. Right, routes of transmission, usually they use a deer as the one there. Infectious granuloma formation. Yeah, all the questions I've seen related to the rabbits. So, but pneumonic, that's the worst way of getting it. if you get that is inhalation, highest mortality, hemorrhagic, okay? And then you can see here, pneumonic, primarily tularemia. That's the one you really don't want to get. Okay. Okay, and contact with urine, there's a couple of those. Leptospirosis, so that's our other spirochete. So syphilis, Lyme disease, and leptospirosis. That's our other spirochete, so that you can find there. So you contact with urine, rodent host, stuff like that. They'll say they were cleaning out a barn or something, so that you can get that way. Urine of infected animals is primarily the cause there, right? And then it goes through this phasic thing, like many things do. Wheel disease, hepatic necrosis not seen, but hepatic necrosis is not seen, and surviving patients do not have permanent hepatic damage. Okay, right. Oh, that's one of the things. They talk about this calf pain. That's very specific for it. Leptospirosis. That's one of the things they like to talk about. Calf pain. It seems it's very specific. Okay, so you can get jaundice, but as it says here, it doesn't. There's no permanent damage. Renal failure, cardiac arrhythmias, stuff like that. Even pulmonary and meningitis. But for some reason, I remember them talking about calf pain, and that was specific for leptospirosis. All right. All right, again, that wheel disease, impaired hepatic function, but not permanent. Okay. Sorry, a lot of this is just jogging my memory. Not a lot of this is high yield for step, so I haven't seen it in a while. Unpasteurized Brucella, Echinococcus, right? So Brucella, undulating fever, again, gram-negative coccobacillus, right? And then the sources are going to be important here. You get this from cattle. That's the big one they talk about. Brucella infections. All right, so yeah. Okay, intracellular parasite. Yeah, none of this is really standing out to me as super high yield. A lot of the vectors are going to be what's important to remember these. Undulating fever, again, this is another one I mentioned earlier. It's relative bradycardia. When you have a fever, you'd expect to have tachycardia. So there's only a few things that will cause that. Yellow fever was the other one we looked at. Okay, bone and joint symptoms. All right. Yeah, big thing here, echinococcus, right? The hyatid cyst in the liver. That's the big thing you want to remember with these. That's going to be your buzzword for these. You can form hyatid cysts that develop in the liver. You can get these from sheep, dogs, right? Abdominal pain. Look at this. It can even spread to the brain. Okay. Rupture of these cysts can be an emergent, can cause anaphylaxis. So that's the big one there that you want to remember for that. Not super high yield. Right. And then foxes to small rodents. Yeah, that's another. Dogs as well. Okay, and you can see where these cysts were, right? They can even get to the spread to the lungs and the brain. All right, so diagnostically, you're looking for those cysts. That's a big thing to remember there. All right, then Coxsackie, remember that can cause heart issues there. So fecal oral route. Yeah. Coxsackie A, you're looking for herpangina, vesicular lesions, whereas Coxsackie B is more of your myocarditis, or really it's pancarditis. It really can cause it anywhere. You can get pleural pain as well. So Coxsackie B is a really important cause of heart infections. There you see the herpangina that develops as well. Yeah, hand, foot, and mouth disease is specific for Coxsackie A. Whereas Coxsackie B, you're looking for heart problems. Okay, EBV, right? That is mononucleosis. So really worried about that splenomegaly. The spleen can rupture. They tell you to take it easy. You're not supposed to play sports. When you get this, just because the spleen is so enlarged, if it ruptures, you can get significant blood loss. Or, right, and then, yeah, watch out for people with transplant AIDS patients, right? This oral leukoplakia as well. You can see here, swollen lymph nodes and large spleen. That's the big one. It takes a couple weeks, couple months even. And so you're worried about that. And of course, it can lead to some sort of, like Burkitt's lymphoma and stuff as well, this latent virus. So be careful with that. Now you use the mononuclear test. Now, if it comes up negative and you still have it, it could be CMV. CMV does prevent like EBV, but the testing for mononucleosis comes back negative. Right, and you can see here, this B cell proliferation with it, unfortunately, can develop to lymphomas, nasopharyngeal carcinomas as well if it's not fully resolved. And then, as I mentioned, the spleen gets very large, and if it ruptures, get a lot of problems with that intra-abdominal bleeding. All right, the monospot test is what you use. This is very high yield. You need to know that the presence of the heterophile antibody, that's what you're looking for EBV. If it's a non-heterophile or it's heterophile negative antibody, it could be CMV mononucleosis. Okay, so it presents very similarly, except this test will come back negative. All right, and here's CMV, right? So we know it can be spread all kind of different ways. You're specifically worried about those AIDS patients, the CD4 count under 50. Right, and here you go, heterophile negative mononucleosis symptoms. Again, you're worried about these individuals. We talked about it in kids, the retinitis, it can cause that as well. So you're worried about that. You're worried about that ear problems in kids as well, the sensorineural hearing loss. And birth defects, yeah, so we talked about that already. Vision or hearing loss, yeah. All right, and then you have these owl eye inclusions, right? That's very specific for CMV as well. Cotton wool retina can form. Yeah. All right. Now, HSV, you've talked about this before, so this is kind of a review. We want to go through a couple of the important things. This little part right here is going to be important. The GAG gene is going to primarily code for the capsid, right? And then the Pol gene, Pol polymerase, you get that reverse transcriptase, which is super important to get that, that RNA virus back to DNA. Protease and integrase. Protease will break down into other parts. Integrase will into its components, the protease, the protein parts, so then they could come together as a virus. Integrase will help to integrate the viral DNA once it's formed into the host DNA, okay? Envelope codes for the envelope. You need to know both of these. GP120 is for binding. GP41 is for fusion, right? And you know that there's some drug targets for that as well. All right, goes through the life cycle. You're kind of familiar with this by now. In the acute phase, the CCR5 attaches primarily to, I think, macrophages, right? Or any of these antigen-presenting cells, CD4 T cells. Then as it progresses, then you're really affecting the CD4 T cells. So that's CXCR4. Okay, again, drug targets are there. So be aware of that. Yeah. Yeah, you have to be careful in utero delivery, even breast milk, that it can be transmitted. So the mother has to be treated beforehand. All right. Right. You can end up with HIV encephalopathy, right? So worried about that, multinucleated giant cells. Almost looks like a granuloma formation, but it's not exactly the same. All right, and then we have our progression. This is very important here. You get this primary infection. So our blue line is looking at our CD4 count, and the red is looking at how many copies of the virus you have. So they should basically be inverse of each other, right? Your CD4 count will go up, down. Sorry, your CD4 count will go down as the viral load goes up, right? So you see this primary infection takes a little while to get going. Once it gets going, your CD4s will drop as your viral load. Now the viral load copies is going to be indicative of how bad the virus is, which makes sense. And then that's going to correlate to how low your CD4s are going to drop. And then you have this latency period where everything's fine. Your CD4s kind of come back up. This is an important little peak here, because once this drops, your CD4s come back up. And then all of a sudden, for whatever reason, you get these constitutional symptoms, and then the viral load will go up, and then these opportunistic infections will be more prevalent. And as your CD4 count goes down, depending on the level, you're susceptible to different infections, right? Whether it's under 200 and it's pneumocystis jirovecii, whether it's under 100 and it's cryptococcus, stuff like that. Under 50, you're worried about CMV and stuff like that. So good thing, go look at first aid. They have them all listed, but those are pretty much the main ones we're worried about. Yeah, diagnostically, yeah, you can go through a couple different ways to do that. Oh, here we go. Yep. Fourth gen ELISA is what you're using. I think that was a testable point. Current guidelines is fourth generation ELISA that you want to use for this. Right. Okay. Yeah, see, fourth gen ELISA. Make sure you know that. Then once you test that, you can do a confirmatory test to see if you want to type it and see if it's 1 or 2. I'm not ideally, but it's probably type 1, which is more prevalent. All right, so as I mentioned, the viral load is kind of is indicative of the severity of the infection and kind of where you're at in the disease process. And also, of course, to monitor how well your therapy is working, because therapy should decrease the viral load overall. And that should subsequently help with the your CD4 count. Right, yeah, of course you want to check for all kind of things, especially STDs and whatnot. Right, and then we'll talk about quickly talk about some of the different antiretroviral therapy. For better or worse, I think we literally had like 2 antiretroviral therapy questions on our exam. I remember trying to learn all these very quickly. And I don't know what that means for y'all. Y'all will probably get like 20 questions on it, but we were very surprised that we only had like 2 of them on there. All right, everybody's favorite. Now, for the antibacterials, as I mentioned earlier, there's not really much I can help with. It's a lot of memorization. I can say, and I did say yesterday, that I was pleasantly surprised at how the test turned out. I felt finishing it, I felt like it was a very fair exam. I felt like they could have made it a lot worse, and they didn't. I felt like a lot of the drug questions were common drug questions. They really didn't try to trick us. They didn't ask us some obscure disease and the 5th line therapy for it. They were very straightforward. So when it comes to the antibacterials, first line, second line, you should be good there. Know how the resistance works, right? So penicillin, cephalosporins have a very similar mechanism with the penicillin binding proteins, the beta-lactamases, okay? But vancomycin is very different. So for MRSA, you don't get resistance from those beta-lactamases. It has a different coding sequence, the diala sequence, right? So it can't bind properly. So that's very different for vancomycin. As for the protein synthesis inhibitors, the tetracyclines, aminoglycosides, so y'all know the mnemonic, right? I'm sure y'all do. I'll just make sure. Give me 1 second. So it's by at 30. And then, let's see if I remember, it's 50. Cell 1L or 2. So this isn't, it's aminoglycosides, tetracyclines, and then what's it? Clindamycin, erythromycin, linezolid. What was the other one? Linezolid.
Chloramphenicol.
Chloramphenicol. Was there one more L, or is that right? I think that may be it. Unless there was one more L in this cell. Anyway, so for these, they have different types of antibiotic resistances. You can double check me or look in first aid that has it, but this, I still try to use this if I can remember it today with the buy at 30, sell at 50, because that's the part of the ribosome that it works with. So yeah, so keep that in mind. To be completely honest with you, I'm sure y'all have a better grasp on these antibiotics than I do, because it's not, it's a good thing. It's not super tested on step. A lot of the things they like to test on is not necessarily what drug works, but how the drug develops resistance and stuff. So there are a few questions where they ask specifics, but for the most part, they're looking at more like antibiotic resistance and stuff like this. So what I'll do is I'll go to yes. So this is what's going to be important when they talk about bacterial endocarditis and stuff like that, and what are your treatments. You always want to give vancomycin and gentamicin, right? So that's probably good enough to know there. Empiric therapy, right? So penicillins always, oh, well, we'll get there when we get there. So alpha hemolytic, right? So these are what you're going to give. Technically, in the States, you give a Z-Pak, but on the test, you always want to start with penicillins first for streptococci, okay? Even if it's strep pharyngitis or strep pyogenes, you want to start with the penicillin before you give, something else, because that's the protocol. And then definitely knowing the differences here, nafcillin and oxacillin with those, and versus like the piperacillin and stuff like that. All right. Right. So again, like you probably can get away with just knowing the first line drug, but if it's something that's highly resistant, such as penicillin, you want to move on to knowing some of the other ones as well. But unfortunately, this is just a lot about memorization. They could ask you differences versus outpatients versus inpatients, and what that they're, they can even, I've seen questions where they do inpatient and they ask for a two drug combination, right? So for here, empiric therapy, you wouldn't just give a fluoroquinolone, you'd have to give the two drug combination. That may have been on one of the IMCQs. And then this is good for respiratory pathogens. You can see here what you're gonna give. Okay, and you can see here, again, unfortunately, I don't have a lot for you. This is a lot of memorization. Here's your Pseudomonas drugs, piperacillin, ticaracillin, that you can give there. C. diff, right? Clindamycin's the big one, all right? Clindamycin's always gonna cause, or not always, but it's most likely gonna cause C. diff once it wipes out your microbial flora. Treat it with vancomycin, any of these, but really vancomycin is ideal. All right. Right, another one that comes up, remember, anytime gonorrhea and chlamydia are typically coexist. When you get a gonorrheal infection, you typically have chlamydia too, so they always treat them together. So what do you give for that? What do you give for gonorrhea? It's ciprofloxacin? No, it's not. Yes, it is. Can somebody help me out?
Ceftriaxone.
That's the other C one. Yeah, ceftriaxone, and then you give you can give doxycycline for the syphilis, but you always treat those together. There's questions that come up where you can give the combination, and you always want to give them together.
And then doesn't erythromycin do like neonatal conjunctivitis for Canada, or sorry, for gonorrhea?
You'd have to double check. Yeah, I'm not sure off the top of my head. I know you can also give erythromycin for the chlamydial infections too. That might maybe first lines azithromycin, but you can also give doxycycline. Yeah, you'd have to double check. I haven't seen a lot of these in a long time. fortunately for me, it's not super high yield on step, these regimens. And then there's some summaries in the back. So if you're, this is more of what's testable going forward. A lot of these different side effects, right? So you're worried about, especially like fluoroquinolones, you don't give it to kids under 8 years old because you're worried about tendon rupture, stuff like that. So it's very good.
Fluoroquinolones are 18.
It's 18.
Not,
thank you.
18
okay.
for those for doxycyclines. It's 8.
Okay, thank you. That makes sense, right? 18, you're still growing, right? So you wouldn't want to give anything for the tendon rupture. Remember, trimethoprim, you can't give that to pregnant women, just like valproate and stuff, because you get folate deficiencies. You are worried about neural tube defects and stuff. Okay, and then prophylaxis you can give. Again, maybe, even first aid is dense in this area. So, but as I mentioned earlier, I did think the test was fair. A lot of this stuff is just, honestly, when you're working in the hospital, you just look it up and see what you're supposed to give. This is a very unique thing, general surgery. Cefazolin, typically you give ceftriaxone for pretty much everything when it comes to cephalosporins, but cefazolin, you want to give prophylactically for general surgery for any sort of skin infection that may get worse, right? And then this is some buzzword stuff, MRSA, you want to give vancomycin, things like that. Okay, even if you suspect there's some sort of staph infection, you would assume that most of the staph infections are resistant to penicillin, so you give vancomycin, and then you check later and see if it is susceptible. You could back off the vancomycin and give something else. Okay, so at least that's the current protocols. All right, let's see what else. Antivirals. So, right, and Dr. Gatos went into all the different, it's a really good lecture on how this all works, and he breaks it down very well. Sorry, hold on. Yeah. So, right, the neuraminidase inhibitors have the MIVR, influenza A and B. That's what you would use for that. Ideally, you would use prophylaxis with some sort of vaccination protocol as well. All right, so these are specific for the neuraminidase inhibitors. This is a good slide to remember. This was a testable point of how they all work, right? So parenterally, what you actually use with this is you see what kind of or actually these drugs indicate what kind of side effects you're going to give. So if you give it parentally, you get different side effects than if you give it orally versus inhaled, okay? So if you give it parentally, you would think pruritus, peeling of the skin, that makes sense. Orally, GI upset, airway irritation there. So just remember these, the MIVIR for the neuraminidase inhibitors. And the neuraminidase is basically preventing the virus from being released. Okay, and then you have these endonuclease inhibitors as well that can be given for influenza A and B, right? Not super high yield, but yeah. It is one drug, so it could be testable. Right, and then if you want to inhibit the RNA-dependent RNA polymerase, preventing genome replication, right? Because if you want to get that RNA virus back to DNA so it can be integrated, you can block that, right? So ribavirin, RSV, that's in kids, typically get that, and then hepatitis C as well, okay? Can't give it to pregnant women, worried about hemolytic anemia. All right, so, and then this is a good little summary for it, okay? These two for influenza, guanosine analog, ribavirin, right? Hepatitis B has its own set of things, interferon alpha, I believe, is what you use here. Yeah, inhibits viral infection. Inhibits RNA and DNA synthesis by inducing protein expression, right? So this protein will inhibit the integration or the synthesis, excuse me. Yeah, here it is, interferon alpha. So you can give it for hepatitis B and C with ribavirin, okay? You won't need to remember these right now, but B is for multiple sclerosis and CGD is gamma because granulomas are specific for interferon gamma. All right, and then that's a good way to remember it. Flu-like symptoms, neutropenia. All right, yeah, and then these nucleoside analogs. So of course that has to do with genome replication. So if you inhibit the viral reverse transcriptase, remember HBV falls in that category 7. So it has like partially double-stranded, partially single-stranded. So you have to take the RNA and get it back to DNA to replicate. And you know, HIV is used that reverse transcriptase. So this is a good point to prevent genome replication, right? And you can see that here. The LATE is the mnemonic here that you can remember, and the end in Veers, right? So, yeah. I wish I had more for you guys. It's just, yeah, unfortunately, this is just a whole lot of just memorization, which is no fun. And then again, he had, Dr. Gatos has this, this summary here as well. Hepatitis C is in its own category as well. So you can see these different inhibitors that can form. Previr is the suffix here that you're looking at, right, and how they work in these inhibitory processes. But go back, I mean, I don't remember them being super high yield, asking where these all fell, but there's non-structural protein and inhibitors as well that these drug targets work on. Again, a good summary. Knowing the summary will get you a long way on these. Reiterate the fact that they really didn't test on a lot of these high yield details. On these details. It was more of the high yield stuff, the stuff that you find, teratogens, common side effects. All right, now the herpes virus, you can see here, latent infection, you're worried about that as well. But these drugs are only gonna work on replicating viruses, which, it's just how they work. I don't know necessarily it's ideal, but if it's latent, it's not really affecting you. So acyclovir is a good one for herpes simplex virus. Remember, it has to be activated by the viral kinase, which is good because if you take the medication, you don't have it, the drug doesn't get activated. And then for CMV, remember you want to use ganciclovir. Cidofovir is for CMV retinitis specifically, and then some other ones for HSV cold sores and the conjunctivitis as well. Okay, so here you go. Remember these acyclovirs, this is commonly tested. Host kinase has to activate it. So it has to be a replicating virus for the drug to be activated. And it causes that chain termination. Remember from FTM1, this doesn't have a 3' OH. So this analog gets put into the DNA sequence and there's nothing for the next nucleotide to bind to. Okay, so that causes this chain termination, so you won't get replication of the virus. Acyclovir, again, commonly tested, HSV. Right. Valganciclovir just it's a precursor, right? So it has a longer availability, it stays in the system. And renal failure is what you're worried about there. Specifically, yeah, they do ask about that. This came up on step questions. This crystalline nephropathy, specific for acyclovir. Now, if you're looking for CMV, you're going ganciclovir, these infections, the retinitis, esophagitis, colitis. Remember, you're looking at immunocompromised patient, ganciclovir or valganciclovir, which is the precursor for it, works. I think the mnemonic they use is gun down the BM, bone marrow, ganciclovir, so it can cause myelosuppression, even neutropenia. So check the blood work on that. Cidofovir, specific for CMV retinitis. Good thing to know there. Again, has to be activated by the host cell kinases for the drug to work. Nephrotoxicity, okay? So cidofovir can cause nephrotoxicity. You can give probenecid with it to prevent that. Not super high yield, but there. Yeah, cold sores, penciclovir, yeah. And then for the conjunctivitis, this is another one you can give as well. Okay, and then foscarnet comes up. It's very specific in that it doesn't require that host cell kinase. It doesn't require phosphorylation, so it can be treated with CMV. For CMV retinitis, but just keep in mind, that's one of the defining characteristics of it because the other ones need to be phosphorylated to be activated. So foscarnet does not. So keep that in mind. Again, nephrotoxicity again, as with the other stuff. All right, this is a great little way of remembering it. Kidneys, nephrotoxic, acyclovir, foscarnet. Remember, foscarnet doesn't need to be phosphorylated to be activated, and cidofovir specifically for that CMV retinitis. All right, and then if you're into tables, maybe just go through this and look at it. Right. All right, what is this? Antiparasitics. I think we might have had 1 or 2 questions and they were pretty straightforward. It was, they didn't ask about some of these very off the wall things. It was just like metronidazole, amoebiasis, yeah, stuff like that. Giardia treatment, right? Watery diarrhea for camping. I'm not saying don't know this. I'm just saying the stuff we were tested on, I was pleasantly surprised, but there's not much I can show you here. PCP for those AIDS patients, you can give TMP SMX, first line, toxoplasmosis, that's a good one to know. The ones I have highlighted here, probably the ones I would make sure to know, metronidazole, right, for those GI problems, and trichomonas as well. Metronidazole, Chagas disease, yeah. So again, the ones I have highlighted are probably the most important ones you need to know. Anti-helminth, the bendazoles, right, they're like worms, so they're bendy. So you remember the bendazoles there. Again, this wasn't super high yield, but if you don't know it, you go with mebendazole because that treats a whole lot of the different ones. Okay. Yeah. And then trematose praziquantel. Yeah. I know it's a lot, but I'm telling you, they went into this exam knowing it was a lot, and they did make it straightforward for us. So I'm hoping it's the same for you guys. All right, and okay, 2 more. Right. Antifungals. So when in doubt, just go ahead and use one of those azoles. Between the azoles and the amphotericin B, a little bit different in how they work. They both work on the cell wall. Remember, these fungi have ergosterol instead of cholesterol. So these azoles, like fluconazole, they work by preventing the ergosterol synthesis. Okay, so you don't synthesize the cell wall, whereas amphotericin B kind of punches holes in the cell wall, punches pores in it, kind of just destroys it. So those are the main 2 that they really use for these broad spectrum, right? So that's what I would definitely commit to memory. Amphotericin B is notorious for renal toxicity, RTA, stuff like that. Yeah, also monitor liver function as well, but the renal problem is the big one. Right, y'all remember this for chemo treatment. DNA synthesis, thymidylate synthase, it blocks that 5-fluorouracil. So similar process here. Yeah, let's see. I don't really think they tested it. They tested us on the azole, so these are good to know. Ketoconazole, again, it prevents that ergosterol synthesis. So knowing that is a step in the right direction. All right, you can see that here. Yeah, even for CNS infections, fungal, CNSF infection, fluconazole can even still be used. Okay, so here's a good slide to remember. Fluconazole for Candida, coccidiomycosis, Cryptococcus, so all those big ones. So when in doubt, go with that for sure. They're notorious for inhibiting your CYP450s. So be careful with that. I'm sorry, yeah, inhibiting, right? Not activating, but inhibiting. So slowing down the breakdown. So you can get toxicity that way of most drugs. All right, here's a specific one, voriconazole, specific for invasive aspergillosis. I don't think that was tested, but it is specific, right? Mucor, remember, that has to do with diabetic patients as well. Unfortunately, when these fungal infections happen, most of the patients are immunocompromised, so they're on immunosuppressants, and it's very dangerous to be giving them drugs that mess up the CYP450s. So it's a very touch and go kind of situation. And then fluconazole is specific for renal elimination, right, or clearance. All right, so some of these other ones, again, wasn't super high yield. I would kind of know the names and kind of how they work. But beyond that, you should be okay. Nystatin, candidiasis, yeah. Right, and then it kind of goes into the different ones. So you could test yourself there, but don't get too hung up. Like if you had a list of things to do, I wouldn't necessarily put this at the top. Right, age patients, CD4 count under 200, clotrimazole or TMP-SMX, get for that, right? All right, last one, we will look at the antiretrovirals quickly. So there are two that have to do, we looked at this, right? This latency, this initial infection, and the 4 Fs, flu-like, feeling fine, falling CD4, final crisis. So you can track it that way if you like. And then, yeah, the whole point is to decrease your viral load, and that will increase your CD4 count. So let's get to some of the drugs. I'll let you guys go. I know you'll have a lot to do. All right, yes, entry fusion inhibitors. Me first is the way that Dr. Gatos described it. So knowing how these works will be a good one. Maraviroc, CCR5, remember that's that early stage in the macrophage. So this will prevent this fusion entry. What is the fusion part? Remember GP41, I think 41 in fusion, like the F and F. Helps me remember that one. And then, yeah, so you can see here, CCR5, that's that early phase. So you want to, this is like that initial infection that you want to use it on there. And see GP41, right? So this is this fusion, 41 in fusion, you can give it Ferbatide. So similar to 41, it helps to prevent fusion entry. So Moraviric is CCR5, works on CCR5, whereas Infirvatide works on the GP41. Okay, same kind of principle, but keep those separate. All right, viral fusion with 41. Okay, and then these are very, very good to remember, these nucleoside reverse transcriptase inhibitors. So they end in Dean, most of them do, Dean or Bean, Seen. St. Zelda is the way to remember those. Right, so idea, competitive inhibitors of reverse transcriptase. So these also have to be phosphorylated because there's another class that doesn't have to be phosphorylated. So keep those in mind. Those are St. Zelda, lacta 3'OH, similar to acyclovir. So you get chain termination there, right? So you don't want to use these alone. Typically they use, I believe, a protease inhibitor as well with it. Yeah, so you definitely don't want to use those alone. We'll get there in a second. And then the side effect profiles are going to be important as well. Peripheral neuropathy, muscle pain, yeah, loss of adipose tissue, even lactic acidosis, and then more serious pancreatitis, myelosuppression, cardiomyopathies, okay? It just depends on the situation. Sometimes these are acceptable side effects depending on the severity of the disease, right? Okay. And then it goes into some of these in more detail. So the stuff I haven't read is kind of the more important things to remember for these specific diseases. And as you know, all of my notes, all these notes that I have here that I took are available on my drive in your folder. So you can look at these if you didn't have time to mark all these down. So it's a good way to remember it. Strong inhibitor of mitochondrial DNA polymerase, and then it could cause peripheral neuropathy and pancreatitis as well. I wrote that in there. So that's stavudine. Tenofovir, GI upset. All right, so this has significant drug interactions. Good to know. And also very specific for it, it's the only NRTI that's a nucleotide. The rest are nucleoside analog. So this is a tide, T for tenofovir and T for tide, if that helps. And you can see these drug interactions here. Zidovudine was kind of AZT. This was kind of in the 1980s, the miracle drug that came about for AIDS patients. Maybe it was the early 90s. But it's classically for neutropenia, macrocytic anemia, and lipoatrophy as well. But the same principle, Black's a 3' OH, so you're not going to be able to replicate that DNA from the reverse transcriptase. Okay, lamivudine resistance as well. Emtricitabine, I guess is how you say it. Very unique characteristic. I would make sure you know that, hyperpigmentation of palms and soles. Okay, so it is one of the preferred treatments. Okay, so because of that and because it has one of these unique characteristics, I would commit that to memory. And then you go, here's the hands and feet. Hyperpigmentation, palms and soles. Okay, good question. Didanosine, pancreatitis, peripheral neuropathy, similar to stabidine. Okay. So that could be, this is actually says no longer recommended due to these unacceptable toxicity. Does that mean it's not tested? Hopefully not, but still, pancreatitis, peripheral neuropathy. All right, abacavir, hypersensitivity reactions. I don't know that this is one that was really tested. But if that helps, yeah, that's a good little way, the AB and HLA. 5701 and abacavir is how it starts. All right, and then you have the non-nucleotide reverse transcriptase inhibitors. So this is REN, that's how you remember these. Okay, so non-competitive inhibitors, okay, whereas the other ones were competitive inhibitors, which means these do not require phosphorylation versus the NRTIs. Okay, so that's how you keep those separate, but they do create chain termination. They just don't compete for that binding site. They have their own allosteric binding site. Okay. Drug-drug interactions, skin rashes, Steven-Johnson, it's problematic. Okay. Yep. Rilpivirine can be used in pregnancy, could cause QT prolongation, but anytime there's something that stands out for pregnancy, you want to commit that to memory. Efavirenz, CNS toxicity, psychiatric disturbances, I believe that is testable, right? If you have someone that has previous history of psychological disturbances, you want to stay away from that. And it can be teratogenic as well. So I would definitely commit that to memory. I feel like I've seen that before. Nevirapine, severe hepatic toxicity, watch out for women with count. Do not use right, because of the severe hepatotoxicity, you want to wait till the count drops, okay? Lower because it's severely hepatotoxic. All right. And then again, now it says that you don't really recommend it. All right. So I guess in worst cases, if it gets bad enough, but now here it says you really don't want to give it. It is only currently used for post-exposure prophylaxis for high-risk infants. So yeah, but you could give zidovudine, right? So that would be the first line for those pregnant women. All right, integrase inhibitors. Remember, the idea is that once the reverse transcriptase takes the RNA, makes it into DNA, you want to integrate that DNA into the host cell genome. So this is going to help to block that. The way to remember this, the little mnemonic is bread. Tegravir is the suffix there. So it's going to help to block the integration. Now, some of these have very specific side effects. With raltegravir and rhabdomyolysis R&R, that's a big one, right? Remember, rhabdomyolysis can lead to renal failure as well. If you're going to give alvitegravir, you need a PK enhancer, which we'll get to in a second. And then again, this one can cause similar symptoms here. So surprisingly, as I said earlier, we had like 2 questions, maybe on these, and it was so convoluted. Learning this stuff. Now the protease inhibitors, Linda is the way to remember that. Navir is how they end. So this is going to help to prevent these, once the DNA is transcribed into proteins, it'll help to prevent this polyprotein from being broken down. That does not require intracellular phosphorylation, okay? So if you inhibit this protein, you're not able to break these different components into their individual parts so they can assemble and then be released, okay? So basically prevents maturation of these protein parts. And then once they're released, they're still in their individual components, or they're not able to compile into the proper viron or virus when it's released. Okay, so yeah, you can see that here. Most require these enhancers, which we'll talk about in a second. And they do have drug interactions, right? And very cushienoid appearance is a specific side effect there. You can see that here. So these are those protease inhibitors. Linda is being teased because she has Cushing syndrome. So that's a good way to remember that. Protease and those. Right, and then there's the side effect profiles for these. But again, all of them can cause this cushienoid syndrome. Right, okay. And then these PK enhancers are typically given with these drugs to help them work better. Ritonavir is the big one, right? So this is kind of how they work. Prevents or increases your tolerability of it, can increase the plasma concentration of the drug, so it's not broken down. So of course, since they're enhancers, you don't use them alone, you use them in conjunction with other drugs, and that helps the other drugs work better. So then they go into these, definitely know these because this is how they're gonna test you on this stuff. So pre-exposure prophylaxis, how you're gonna give it post-exposure, you kind of add one of these protease inhibitors or these integrase inhibitors as well, right? And then preferred treatment for post-exposure, it's always a 3-drug combination, a PI plus the NRTI, okay? So keep those in mind. Yeah, and you can see, I'm not gonna read these off to you, but you can see, very importantly, start this Zidovudine is what you wanna give for pregnant mothers. And infants, make sure you know this, Zidovudine, or you can add nevirapine to it. So that is it. I do apologize. I know with the drug stuff, I mean, I'm just reading a lot of the side effects to you. There's not much to it more than that, but know how resistance works. Know oh, y'all didn't have Dr. Gatos? Oh, yeah, his slides are great. I hope that was helpful. I like a lot of his mnemonics. But know how the side effect profile, know how resistance works, know some of the really bad side effects and the drug combinations. But besides that, I consider it medium to low yield. Don't neglect the pathology and stuff. But other than that, I think that's it, unless y'all had any questions. Okay, well, another 3-hour review. Good luck on your exam tomorrow. I'm sure y'all will do great. And as for the going forward, the BSCs, y'all can cross that bridge when you get there. Anyway, good luck. I'll talk to you guys later.